This is hall B.
वाह सेक्रेटरी साहब एकदम सूट बीट में बहुत.
Always.
हाँ अरे हॉल ए में जाता हूँ.
Yeah. So you checked your presentation, right? Zaviri sir. Virtual background and all.
Virtual background डाल रहा है
हाँ डालना है.
तो सेटिंग में आता है.
उसको अब ऐड करना है. Arjun, where is Agnivesh?
I'll just call him.
Yeah. We have a few minutes. I'll just, at 9 o'clock, I'll welcome everyone, introduce the session, and then I'll hand it over to Arjun and Agnivesh. And then they will introduce the topic and introduce you, Manish, and then your talk starts. And that is how it will go on then. In general, I'm just going to be looking at both the programs, so I'm not going to be involved too much. If there is any silent moment, I'll come in, but I doubt it will be required in today's meeting.
Hello.
Yeah, Manish.
I'm just putting this BSS virtual background. Is it coming? Is it appearing?
Yes, it's there. It's there.
No, is it? But it is flip-sided. मेरे को उल्टा दिख रहा है वो.
No, it looks correct.
बराबर है. Okay.
Yes.
But then he's joining, huh?
Yeah.
So are we having questions in the chat box, or are there questions coming on the
So we may get a couple of questions in the chat box. Whatever is there, वो आ जाएगा. I will direct you towards it, but that's going to be much less than what you expect.
Okay.
So you'll have to, as we discussed earlier, your planning is most important. So you'll have to take the discussion around. But with people, our seniors like Dr. Zaveri and Dalvi and all around, and Kudnani and all around, there should not be any problem in discussions. It'll just let it go organically where it needs to.
Okay. But is there any place where the audience puts questions or what? Or is there
Yes,
anything
yes. So the audience will put up questions, and even Suvidha will
Let us
put up this those and a flow chart for the audience how to put up their questions,
okay.
and those questions will be relayed here, which you can take.
Okay, they'll be relayed. Okay.
Yes.
They're in the
So
chat
we are
box.
live already, but we will be starting officially at 9 o'clock
Perfect.
sharp.
Okay.
Arjun, can you check with Vishal?
All right, I'll do that.
So we'll be starting in a few minutes, in a few seconds. Suvidha, you have to put up slides in between for delegates on how to ask questions.
Yes, sir.
All right. So good morning, everybody. On behalf of Bombay Spine Society, I welcome all of you. I welcome our esteemed faculty who are here to make this a very interesting session. Today is the second day, and this is Hall B, where you'll be watching on surgeries on percutaneous procedures in spine. We also have a Hall A, where minimally invasive lumbar fusion techniques are being discussed. So we have our hall in charges, Dr. Agnivesh Tikku and Dr. Arjun Dawale, who will be taking over the proceedings. They will be guiding you throughout this. I encourage all our delegates to ask questions. We got a few questions yesterday, but you could have a better participation by clicking on your asking questions box, and you can we'll put it over to our faculty here. So over to you, Arjun. Arjun and Agnivesh.
Yeah, hi, good morning. I'm here. I think Dr. Arjun had some issue. He has exited. He'll be relogging.
Sure. You can introduce our topic speaker and then we can start the meeting.
Right. So, good morning, everyone. On behalf of the Bombay Spine Society, I welcome you to this session. And we are going to have the first talk by Dr. Manish Kothari. And he's a well-renowned spine surgeon in Western Line, Jaslok Hospital. Suvita, can you please play the talk?
So this is Dr. Manish Kothari. Today I'm going to talk about contraindications of vertebroplasty. So when we talk about contraindications, the first thing you want to know is what are the goals of vertebroplasty. Of course, the goals being pain relief, avoiding complications, and prevent future collapse. So all of this you can know by the main parameter for this is knowing the fracture type and which ones is going to behave which way. So let's look at the fracture types we have. As per the new simplified AO classification, we have the A1, 2, 3, 4 and the B types. So starting from A1, these are the isolated superior or the inferior end plate fractures where the end plate is relatively intact, the disc is not degenerated, there is no deformity on standing X-rays. They present early and many will actually heal conservatively as well. And if you have to do a vertebroplasty in these, a simple targeted vertebroplasty at the fracture will give fantastic results. Next, we come to the A2 type. This is also the pincer type, which is common in osteoporotic fractures. In this, both the end plates are coronally split and there is no significant burst component. The adjacent disc is relatively okay. Now, the feature of this fracture is that it has a propensity of non-union and progressive kyphosis. Let's look at this one study by Goldstein et al. They looked at all conservatively treated osteoporotic fractures and with short to long medium-term follow-up. They saw that A2 and A4 type of fractures will have a further 25% collapse. A2 has the highest propensity for kyphosis development. Both A2 and A4 had the highest propensity of developing an intravertebral vacuum phenomenon, or what is also called as the cleft. And these cases with A2 and A4, and in addition having an intravertebral cleft has the highest risk of developing severe collapse. So let's look at this case. This was a simple A2 fracture with also an anterior wall fracture. It became vertebra plana in 3 months' time. Another case, it's a vertebra plana in an A2 fracture. You look at the prone lateral and sitting X-ray, and you see the movement inside the fracture, and there is complete separation of the anterior 2/3 of the vertebral body from the posterior 1/3. So this this newer system, which is kind of something similar to a kyphoplasty, they looked at the results in A2, 3, and 4 type of fractures. So the A3 and A4, which are the burst fractures, had good results, but A2 was the one which has the highest risk factor for complications, thus giving poorer results in many of such patients. Now we come to the A3 and A4 fractures, which are essentially the main concern is the posterior wall break and the burst component, where we fear that the cement may leak inside the spinal canal because the walls of the fractures are not confined posteriorly. However, if you look at the studies, especially this one in European Spine Journal, from stable burst fractures, the A3 type, all had good results. There was high incidence of cement leak, although this was a general cement leak, including disc and paravertebral, not necessarily spinal. Overall, they had high cement leak, but they were not clinically significant. Next, you look at the studies which have pure posterior wall fractures only. One from the International Spine Journal, very recent. They had 157 fractures treated with kyphoplasty, with the rationale that kyphoplasty has lesser cement leak, and they noted 9% leak in the spinal canal, but none were symptomatic. Another study, 2018, they used kyphoplasty for posterior wall fractures, and 98 patients were treated with no spinal canal leak. So somewhere it is probably technique dependent also. Now, this study by Moser et al., again very recent study, they compared kyphoplasty with addition of screws as the other group. So kyphoplasty on one side and kyphoplasty plus pedicle screws on the other side in fractures with posterior wall breach. And they noted there was no difference there was no difference in the clinical results, and there was no difference in the cement leak. Of course, cement leak is dependent on the balloon kyphoplasty, but adding pedicle screws in such patients made no difference to the end result. So studies are up on one side, but also when you look at clinically, you need to differentiate between an axially stable fracture versus an axially unstable fracture. Now, also these are not the same as traumatic fractures, because many times these fractures partially heal, consolidate. Many are put on conservative treatment, and then they come to you. But as they come to you in a delayed manner, a different type, which is specially seen in osteoporosis only, is the Kummel's lesion or osteovertebral necrosis. Now, these kind of cases in initial days used to be the vertebroplasty or kyphoplasty used to be the gold standard. But as time went by, we saw more and more cases where these intravertebral cleft cases started developing complications, where the cement kind of, there was progressive collapse around the cement and also kyphosis. This one by Lim et al. Noticed that there was a angular instability on the CT scan on the flexion and extension. And after doing a reasonably good vertebroplasty, they realized that the cement was getting detached from the vertebra and they had to be revised. Another study by our very own Dr. Nene, they noticed 5 such cases with an incidence of around 7%. The first one, again, similar picture where the cement is getting detached from the original vertebral body over time. Another one, there is, again, it is almost detached from the vertebral body and there is halo around the cement. A third one, again, the cement is getting detached from the vertebral body, but luckily it was the nature took care of it. So they noted 7% incidence of post-vertebroplasty instability. 2 had intravertebral instability, which is the cleft, and 3 had intervertebral instability. We'll look at it later. And they theorized that the cement acts like a rock between cushions of soft osteoporotic bones. However, of note is that we don't have the pre-op images in this paper. Similar study is by Ha et al. They looked at failure cases of vertebroplasty. They looked at failure cases of vertebroplasty or kyphoplasty. So there were other common mistakes, which are misdiagnosis, missed infection, and iatrogenic infections, which needed revision. However, of note for us is there was progressive collapse in cement injected vertebra, and in such 8 collapses, 7 had a solid pattern of cement distribution. As noted by Dr. Nene, there was a rock of cement in between soft bones, and 5 of 8 had a preoperative intravertebral cleft, which is the Kummel's lesion. And they noted that if there is a halo formation after the vertebroplasty on your follow-up, then that is a poor prognostic indicator. Now, some fractures are difficult to classify, and that is where the Kummel's lesion comes in, and it will take you in the mouth of danger. So, trying to understand the Kummel's lesion better, it was first described by Howard Steele in 1955, and later better research and better stages have been described. So, stage 1 is where there is minimal collapse and the adjacent disc is not degenerated. Stage 2, where the kyphosis has increased and the disc is also starting to degenerate, but there is only this intravertebral instability. And stage 3 is where there is posterior break of the cortex and there is cord compression with kyphosis. Now, in the lines of adult deformity classification, we now have classification for Kummel's lesion also by Formica et al. From Italy, and they give 4 stages from 0, 1 to 3, and they give riders in the form of angular kyphosis and sagittal alignment, which becomes important. So the classification is, and they also give treatment-based guidelines based on the classification. So let's looking at the type of fractures that we treat. Again, another study by Dr. Nene et al. They looked at 134 osteoporotic fractures, of which 17 were healed conservatively, 77 underwent successfully vertebroplasty, and the rest needed some form of modified treatment. Let's look at the groups that they found. Group 1 was non-union, which was the one with the cleft but with intact end plates. They had axial instability of intravertebral type. There was no kyphosis, and there was some canal compromise but no deficit. So they chose to do open decompression followed by vertebroplasty without fixation. Group 2 was where there was mild kyphosis. There was a intravertebral instability, but the patients had neurological deficit. So they decided to decompress, do vertebroplasty as well as fix, which is add screws. And other groups were with higher kyphosis and higher neurological deficit, so which needed some form of osteotomy, as you can see in these groups. Now, another study where they looked at this is a very recent study from 2021 itself, and they have noticed that identifying the correct type of Kummel's lesion by pre-op investigations, including dynamic X-rays, you can properly select and have fantastic results. So they compared vertebroplasty and kyphoplasty in the treatment of neurologically intact Kummel's lesion, and they found fantastic results in all. In fact, they said that vertebroplasty is preferred than kyphoplasty because it is simple with lesser radiation and lesser cost. Now, coming to metastatic lesions. So originally, rather historically, metastasis is always considered kind of a tricky case for vertebroplasty. There used to be horrendous cement leaks in the early days. But as our experience and as our techniques have refined, we have kind of learned better and to choose better for these metastatic lesions. So this one study from 2019, they noted that both vertebroplasty and kyphoplasty had significant relief to the patient in terms of pain. So the patients who have underwent prior treatment like radiation or embolization, or sometimes nowadays we are even doing radiofrequency ablation, they will tend to have less leaks because the tumor is kind of dissolved and there is an empty cavity which the cement can fill in. And also lytic lesions of lung mets can have good results. So coming to the end of the talk, where there are other generic contraindications which are common to most surgeries, also bleeding diathesis. Any infective process elsewhere in the body is better to wait, treat the infection and then come to your vertebroplasty. And also there is a case of missed diagnosis. Many times you miss an early infection as a simple fracture, especially on the screening MRIs. So always do a proper MRI and never perform surgical decisions based on screening MRIs. And so to summarize, contraindications are not hard and fast. These are all contraindications are kind of relative, as I would kind of put it. Most important is your preoperative assessment with dynamic X-rays and CT, where cases where you need to be very careful and avoid isolated vertebroplasty is those with anterior A2 fractures with anterior cortical breach, add fixation to these fractures. Again, A4 with posterior cortical ballooning or with neurological deficit, add fixation to these fractures. Advanced Kummel lesion with intervertebral instability and or kyphosis, you must add some form of fixation. And those with intervertebral instability with a very advanced disc next to it or completely damaged end plate next to it, that will need some form of fixation. In metastatic cases, avoid those with posterior cortex is kind of occupied by the tumor or there is epidural extension, and prefer to do after some form of treatment in the form of radiation or radiotherapy or radioablation.
Thank you, Manish. So before we go on, I just like a little elaboration on the indications for vertebroplasty from the panelists, starting with Manish, and then of course Dr. Zaveri and Dr. Dalvi. So can we quickly have a few points so that we can discuss.
If I start indications, I'm not going to talk about the duration, the time duration. Of course, you have to wait and all those things. But indications and contraindications are a mix of spectrum, and you will choose to do one procedure in one, and the same if the patient profile is different, you will choose to do a rather simpler procedure. But indications would be a early stage Kumel lesion, a simple A1 fracture, even an A3 and A4 can also undergo if the posterior wall is not ballooning and there is no deficit. And in the very elderly, beyond 85, someone is very frail, then no matter what the fracture is, you can still attempt a vertebroplasty. Sometimes they have been life-saving. They're so bad metabolically that vertebroplasties have helped. So, as I said, indications, contraindications are kind of a spectrum.
Dr. Dalvi?
So, I mean, Gautam has a full talk on it. I think for me right now, vertebroplasty has become an extreme sort of exception rather than a rule. You know, we were so enthusiastic about it 15 years ago, and I did 25 to 30 a year those days. Now I might be doing a max of 2 a year. So it's an extreme exception. It's like just the end of the line and we have nothing left to do, then I would do a vertebroplasty. So those patients who are severely symptomatic, who have instabilities, and you know, we've seen Manish's excellent talk on how to select them. Many of them actually come into, to find that little window of people where vertebroplasty will work and they will benefit is a very small window. On this side of the window, there are the people who who will get better by themselves. And on the other side are those who will have problems with vertebroplasty and they may need really some kind of fixation in addition to vertebroplasty. So I would do maybe a percutaneous screw above and below and then do the vertebroplasty. But vertebroplasty alone, it's a very much shrinking indication. And although those patients do tend to feel better immediately, maybe, but that too never 100%. And our Indian patients somehow they want 100%. But in the long run, once you follow up these patients, you see the problems which come. So they have these, you know, pericement fractures, they have adjacent fractures. And you know, whether you can always say that, oh, that's because of the bone quality. But the fact of the matter is that, you know, the vertebroplasty has not worked for these patients. And that's what I'm just trying to it's a very appealing procedure. It's so simple and you feel, wow, you can do it. But as you mature and you start seeing your results, you realize that you should be doing less and less.
Thank you, sir. So I'm going to hand it over to Dr. Zaveri for his talk.
Yeah, thank you, Arjun. Thank you, Agnivesh. And let us start off straight away. Vertebroplasty, I still feel, is an opportunity to do good for your patient. Select the right patient and the right indication. As you all know, it's a minimally invasive technique that involves augmenting the vertebral body using percutaneous injections of bone cement with two goals in mind. One is to provide pain relief, and second goal sometimes is to increase the strength and stiffness so as to reduce the risk of vertebral collapse. How does vertebroplasty work? Nobody is really very sure, but it's the two theories which are being postulated are that bone cement increases the strength and stiffness of that vertebral body. And the second one is that it works by neuroablation. That is, the heat generated by the cement during curing may destroy the painful nerve endings. This is a little bit doubtful because if you look at some of the modern cements which have been coming in, which is the calcium phosphate cements, etc., they do not have such high curing temperatures, and yet the pain relief is equivalent. And therefore, this theory is a little bit doubtful.
Before you go ahead, Dr. Zaveri, can I request you to remove your virtual background as we can't see you?
Oh, I'm so sorry. I didn't know that I had a virtual background. All right. Can you see me now?
Yes, sir.
Yeah. All right. So what are the indications of vertebroplasty? As Samir just mentioned, the indications for vertebroplasty have been shrinking over time, not only because long-term results may not be very good, but as you go ahead with time, you realize that some of the indications which you thought, like, for example, the case where Manish Kothari showed that there was, if you have a large blob of cement in the vertebral body, and that was intervertebral instability. That was intervertebral instability to start with, not something which developed secondary to injection of cement. So this was a contraindication to do a vertebroplasty. It was a badly selected patient. So let us start with some of the indications. The first and foremost indication is a painful osteoporotic vertebral fracture, which is not responding to adequate non-operative treatment. So here, this is the type of fracture. It shows a hyperintensity signal. on a T2 weighted image or a stir contrast MRI. Painful vertebral pseudoarthrosis, as Manish mentioned, is a little controversial, but still, unless the defect or the cleft is very big, unless the cleft is opening up anteriorly or posteriorly, or if the vertebral height restoration in the extension film is very, very big, a painful vertebral pseudoarthrosis can still probably be treated with this type of a problem. Painful pathological fracture secondary to spinal metastasis is a fairly common and a good indication to do a vertebroplasty. Nowadays, with CT scans and MRI scans, Tanechi and the SIN score enable us to identify impending pathological fractures in patients with spinal metastasis, and such patients would benefit from a vertebroplasty. What is being strongly recommended is that when one does long thoracolumbar fusion in osteoporotic elderly patients, one should do a vertebroplasty at the last instrumented segment and the one above that in order to prevent proximal junctional failure or fracture. And of course, this is a rare indication, and that is painful vertebral hemangiomas, where you can attribute the pain only to the hemangioma. The contraindications have already been mentioned. The presence of a neurologic deficit is an absolute contraindication to doing vertebroplasty. Manish mentioned this. AO type B or C, which are basically fractures where there is a ligamentous injury and intervertebral instability, these are contraindications for a vertebroplasty. A large intravertebral defect, if you have something like this, where on an extension film you can see that the vertebra is opening up completely and that the amount of cement that you would have to inject is more than the amount of bone which is there in the vertebra, the chances that this cement will integrate with the bone is very, very poor. And the vertebra actually collapses around this bone. And therefore, this is a very poor indication for doing a vertebroplasty, like some of the cases which Manish mentioned in a series. Anterior vertebral wall defect and posterior vertebral wall deficiency are relative contraindications because now we have techniques by which we can avoid cement leakage in these patients. Intracanal extension of a spinal tumor. And of course, there are relative active infection, especially pyogenic infection. I have done accidentally in tubercular infections a vertebroplasty, but that has not really affected the eventual outcome. But pyogenic infection certainly, bleeding abnormalities, severe pulmonary disease. If a person is already having a severe pulmonary disease, even a small amount of cement embolism can push the patient over the edge, requiring then a mechanical ventilatory support. And therefore, one should be very, very careful about choosing these patients. And patients with severe cardiac compromise who may not be able to lie down in the prone position for a long time and who may have problems during cement curing when the blood pressure falls or cardiac effects can occur. What about the timing? 80% of the patients with osteoporotic fractures obtain significant pain relief within the first 3 to 6 weeks following the injury. Vertebroplasty is therefore avoided during the first 3 to 4 weeks, and then it is at between the 3 to 8 week period where patient is persistently painful that one would consider doing it. There are sometimes patients with kidney disability, renal failure, liver failure, who come to us with osteoporotic vertebral fractures. Here, putting the patient in bed can result in major problems. And therefore, vertebroplasty can be considered early to enable faster mobilization. What are the pre-op investigations that I do? I always do a AP and lateral X-ray in both the supine and loading X-rays are done to basically look for intervertebral instability and to assess the intravertebral defect. MRI scans are done because the hyperintensity signal identifies the painful vertebra. As you can see in this image, the patient had multiple vertebral fractures, but not all of them are fresh. Only the ones at L4 and L5 are fresh and may be the cause of the pain. It also helps us to rule out other pathological conditions and identify any ligamentous injury. Usually CT scan is unnecessary unless you want to study the morphology of the fracture more in detail in order to plan your procedure. What is the equipment? I think the sole equipment which is not challengeable is a good quality, a high quality CAM machine and a very good CAM technician. All the problems that can occur with vertebroplasty are in the initial phase during the selection and during the injection of the cement. And therefore, if you don't have a good quality CAM, it's probably better not to do a vertebroplasty in your setup. Local anesthetic, dye, a vertebroplasty needle, and bone cement. Let's talk a little bit about each one of these. The CAM, as I mentioned, is to be a biplanar imaging. Good quality CAM. Make sure you adjust the patient so that there is ease of moving your CAM into AP and lateral, which is frequently required. So you need to be easily able to move it. Generally, it requires the table to be much higher than the normal so that you can move it from AP to lateral easily. Anesthetic, we use a combination of local anesthesis, but with conscious sedation. You want the patient to be conscious because you want him to provide feedback regarding the neurology when you're injecting cement. So you want to know that there is no leakage. I generally use a combination of 10 ml of sensorcaine 0.25% and mix it with 10 ml of lignocaine 2%. And then we use 1 ml of soda bicarb to avoid the stinging pain. When putting the soda bicarb into the solution, make sure you put it drop by drop and avoid turbidity within the solution. The dye which I use is an omnipaque. It is used to identify leakages into the vertebral venous plexus, epidural veins, and into the epidural space. Usually 1 to 2 cc is all that is required. Check for allergies before you inject any dye, and caution should be exercised while using dye in patients with kidney disease. Vertebroplasty needle. What needle? Number of needles are now available in the market. The most commonly used needle is the Jamshidi vertebral bone biopsy needle. I use a 10 gauge or an 11 gauge needle. 10 centimeters long is what is normally required unless you are doing it in the lumbar spine in a very obese patient where a 15 centimeter long needle is used. The longer needle has the disadvantage that as you put it, pressure it in, the needle tends to bend a little bit and there is a toggle there. Some of the newer vertebroplasty needles which are come in the market are not beveled in the front. They are just serrated and you can push it in. However, I prefer the vertebroplasty needle, because the bone biopsy needle, because often a biopsy is also done along with the procedure. What about bone cement? Again, a number of cements are commercially available. What are the requirements for an ideal vertebroplasty cement? It should be less viscous so that the pressure that you require to inject the cement in is lesser. It should be more radiopaque so you can easily see the cement when you are injecting it. It should not spread after your injection too much, so less spreadability. It should have a longer setting time so that you get a lot more time to do your work. And if you can get an antibiotic loaded cement, that is even better. For all these years, I've been using a combination of Simplex P cement. I take a half dose of Simplex cement for 1 or 2 levels of vertebroplasty. So that is 20 grams. What I do is we remove 10 grams from this packet initially, and then mix 10 grams of barium sulfate to this. That reconstitutes the cement and makes it 20 grams. The barium sulfate adds radio opacity and therefore helps you to visualize your vertebroplasty. The cement and the barium sulfate must be kept in the fridge overnight and brought into the theater just prior to injection. Let's now talk about the surgical technique. One, the patient is taken to the theater. An IV line is secured because in case there is any emergency, prophylactic antibiotics are given, a conscious sedation is maintained, monitor the cardiac status and the oxygen saturation. The positioning, different people prefer different positions. Patients with osteoporotic fractures are extremely painful and have a limited capacity to lie prone. And therefore, the entire theater setup must be completely ready before you wheel in the patient and position the patient. Again, different people position the patients differently. This is Dr. Manish Kothari's picture, X-rays or photographs, where he positions the patient with a pillow below the lower back and or below the hips and below the chest, so as to give a little bit of lordosis and help opening up of the vertebra. I do not do anything of this. I do not like the vertebra to open up too much, because the more you open it up, the more is the problem with amount of cement that goes in, and the more is the risk of failure or fracture or recollapse of that vertebra. So I do not like to do much of a vertebral height correction. That is the message I wanted to give here. So that is what we do. The next step, of course, is to localize. Before you wash up for the procedure, make sure that you have adjusted the Siam the way you want. Once you have started the procedure, everything should depend upon, if you need any further clear images, you must use tilting of the table rather than tilting the Siam. So make sure you position the Siam and take an epilateral view. Make sure the vertebrae is squared so that you can see crisp end plates, and that the spinous processes are in the midline so that you can see the pedicles very clearly. Only after you've seen these things should you start the procedure of vertebroplasty. The next step, of course, is to give local anesthesia. And here, the first step is to give superficial anesthesia, where I inject the local into the skin, subcute, and into the muscles using a smaller 1-inch 22G needle. The next step, of course, is to go with the deeper anesthesia. And here what we do is we use a 20-gauge spinal needle. This goes all the way up to the facet joint, the facetal capsule, and the periosteum, and we inject into this area in order to give good infiltration when the needle is good pain relief when the needle is being put in. The needle insertion. Now, the needle can be inserted in multiple ways. In the upper thoracic spine, what is preferred is the extrapedicular approach, which uses the pedicle rib unit as an effective way of entering, so that you don't end up going into the canal, because the upper thoracic pedicles are relatively smaller in diameter. In the T8 to L5 segment, I prefer to use the transpedicular approach. But if for some reason the pedicle is damaged, one can choose to use a posterolateral approach to do the same procedure. And this is the posterolateral approach. Now, should you do a unipedicular or a bipedicular injection? A majority of the times, especially if there are pseudoarthrotic clefts within the vertebral body, a unipedicular injection is enough and has been shown to have very good results. I generally end up doing bipedicular when I want a separate vertebral biopsy. Then I take a biopsy from one side, and from the opposite side, I do the vertebroplasty. There were some worries that if you do multiple level unipedicular vertebroplasty, then there can be a toggle and there can be unequal distribution of weights causing back pain, but these worries have not been found to be true. The next step, of course, is the needle insertion actually. So you have an incision which is 1 centimeter lateral to the lateral wall of the pedicles as seen. Then you put in the needle. The needle is on this right side. You can see the needle is inserted between 11 and 1 o'clock position, between the 9 and 12 o'clock positions. And on the entry point on the other side is between the 1 and 3 o'clock positions that are there. So that is where the entry point is done of the vertebrae. As you said, showed here 9 to 11 and then 1 to 3. These are the entry points. The entry point is superior in the mid and upper thoracic spine. As you come down from the thoracic spine into the lumbar spine, gradually the entry point becomes more and more caudal, so that you end up going through the midpoint of the pedicle, that is at 3 o'clock or at 9 o'clock in the lumbar spine. The first step is to just push the needle in through the posterior cortex of the vertebral body. And when you do that, you must make sure you are at the lateral border of the pedicle. Once you have done that, the next step is to keep on advancing. You start the procedure in the AP view. In the AP view, you mark the lateral border of the pedicle, and you go in the 9 to 11 o'clock or the 1 to 3 o'clock positions as respectively. And then you hammer it in. Once you hammered the needle in, immediately move the C-arm to the lateral view and check that you are in the level of the pedicle. Now you can adjust the needle to go slightly more medially, slightly more inferiorly as you want, depending upon where you have entered. And then you advance the needle in. The next step comes when you reach the on the lateral view, the posterior wall of the vertebral body. When you reach the posterior vertebral wall, you have ended the pedicle. You are now entering the vertebral body. That means the pedicle is over. If at this stage your needle is lateral to the medial wall of the pedicle, you are within the pedicle. If it has already crossed the medial wall of the pedicle, then you are medial to the pedicle in the spinal canal, and that is wrong, as I have shown with the red cross below. So take a picture when you have reached the posterior wall of the vertebral body. At this point, you must be lateral to the medial wall of the vertebra. And if you are lateral to the medial wall of vertebra, you can then angulate further and push your needle in further into the vertebral body. So you can have one of three situations. In the first situation, when you reach the posterior wall of the vertebral body, you may already be slightly medial as shown in the X-ray over here. And then you tend to go ahead medially and have violated the spinal canal. Sometimes you have started too laterally, and when you go, you end up outside the vertebral body. The ideal thing is in this case, where when you reach the posterior wall of the vertebral body, you are still medial to the lateral to the medial border of the pedicle. If once you've reached that, then you start hammering, go back to the lateral view, and then start hammering the needle in, advance it up to the middle of the vertebral body or to the junction of the anterior 1/3 and posterior 2/3 of the vertebral body. Or if you can, if there is a pseudoarthrotic cleft and you can manage to get it into the pseudoarthrotic cleft, it is very good. Once you have done that, the next step is, of course, to confirm that this needle is now not causing any of the problems. That is, that it is not within the vertebral venous plexus, that there is no leakage of cement into the epidural canal or into the paraspinal veins. If the dye does leak, you can consider either advancing the needle a little bit or withdrawing the needle a few millimeters. You can delay your cement injection till viscosity increases a little bit so that the spreadability of the cement reduces. And even so, you must have a very close observation during cement injection to see if there is any leakage. If there is, then the procedure must be abandoned. Now that your needle is in position, you've confirmed that the dye is not leaking, it's time to get the cement out of your fridge. Barium sulfate, which is ETO'd, is very granular. So once I get the barium sulfate, I actually use a hammer and powder it so that it becomes completely fine in consistency. Then you take the simplex simpent, half dose, that is 20 grams, and you get rid of half the dose, which is, and make it 10 grams. Then add 10 grams of barium sulfate, and then to that you add the monomer. Once the cement is in the fluid state, you pour the cement into a 20 cc syringe, and that syringe then is used to fill the 1 and 2 cc syringes that we use for cement injection. So this is how you do the cement injection. So this is a video provided by Dr. Manish Kothari. He does it a little bit differently from what I do. I actually have the cement. So Then you have taken the cement in 2 cc syringes. They may be with lure lock. Some people prefer a lure lock needle so that it locks with the cement. I do not prefer a lure lock syringe. And the cement is then you wait till the right consistency is achieved. When is the right consistency? When you inject the cement a little bit onto the bed sheet or the covering drape, and it doesn't run down the side, that is the right side. This toothpaste consistency, in my words, is a little too late, because then it becomes very difficult to inject the cement, and it becomes very and the force required is much higher. You have to go a little earlier than this toothpaste consistency. You have to go when the cement is still slightly fluid, but it is at that stage when it is not running down the sides. The injection, the most key thing is that you should inject only 0.1 to 0.2 cc at a time. You inject 0.1 to 0.2, push it in, inject another 0.1 to 0.2, push it in, and you have to do a close observation under SIAM. In the beginning, when I started vertebroplasty, I used to take a image shoot after every 0.1 or 0.2 cc. Now that I know how it is working, I do it after about every third or fourth alicot of 0.1 or 0.2 cc has gone in. If there is a leakage during the dye injection, what I try to do, or if there is an anterior wall defect, what I try to do is I inject 0.1 to 0.5 to 1 cc initially and wait for that cement to somewhat harden. And that then forms like a wall which contains the remaining cement as it goes in. And that is a technique which I have found extremely useful. Stop the cement injection when the cement starts spreading into the posterior 1/3 of the vertebra, or if there is cement leak outside the canal. In the lateral view, you will know whether there is canal, where there is leakage in the canal if it is going beyond the posterior wall of the vertebral body. In the AP view, you cannot make out there whether there is a leak into the canal, but you can make out whether there is leak outside the vertebral body laterally. So you take an AP view. I don't find it very useful when deciding about cement leakage. I do it once during the procedure after I have put in a little bit to see whether there is any lateral leakage. But the main view under which cement injection goes on is the lateral view. How much cement should you inject? You should inject between about 1.5 to 4.5 cc of bone cement. More cement does not seem to provide better pain relief. In fact, increasing the quanta of cement increases the risk of leakage. Increasing the quanta of cement increases the vertebral stiffness and therefore increases the risk of collapse of the same vertebral body. Once cementing is done, you wait for the cement to set outside. That takes about 10 minutes or so. Then remove the needle in a rotary movement so as to detach the needle from the cement. If you remove the cement early, the cement tracks up the needle path and looks like an icicle which is coming out through the pedicle and into the soft tissue. Post-procedural, patient is almost immediately mobilized with the physiotherapist, discharged the same evening. Do not forget to start calcium, vitamin D, and anti-osteoporotic agents. It is this actually which is the prime treatment. The vertebroplasty is just a treatment to treat the mechanical sequelae of this biological disease. This is a 64-year-old woman who had persistent pain secondary to a steroid-induced osteoporotic vertebral fracture, where we had done a vertebroplasty. Another patient, 77-year-old, with a fall who had multiple osteoporotic fractures. And although these images don't seem to light up all through, they were lighting up on the STIR images, and patient was unable to stand and walk due to the pain. We did a multi-level vertebroplasty with an excellent result. What are the complications? I think the major complication that everybody worries about is cement leakage. Cement leakage does occur in between 20 to 60% of patients. However, in a majority of the patients, it is asymptomatic. The worrisome leakage is a pulmonary embolism. I've had one patient who had a pulmonary embolism, cement embolism, because of which she died intraoperatively. And that was very early in my vertebroplasty career, and I was absolutely shattered. And next time I did vertebroplasty, I remember I invited Dr. Samir Dalvi to give me a hand so that I could gain my confidence back in doing this procedure. Neurologic deficits, if your cement leaks into the canal, you can get a nerve root compromise that which occurs in about 4% of patients, or a myelopathy, which is there in even lesser. If you're going through an extrapedicular route, you may land up with rib fractures in the thoracic spine. And of course, I'm worried about doing CT guided vertebroplasties because of the type of sterility maintained in the radiology suite, because majority of infections come from there. Our results, over 16 years, we've done about 200 odd vertebroplasties. Average has been 1.6 levels. This procedure is good because it is done in elderly patients who may not be able to tolerate general anesthesia very well, because this is done under local. They cannot tolerate major surgical procedures. So you're doing it a simple procedure in order to provide pain relief. A majority of the pain relief comes within 24 to 48 hours. And pain scores reduce significantly. Here are my complications. One recurrent fracture after a fall. One patient had a in the evening of the surgery, she was fine. And then in the next morning, she had developed a foot drop straight. And we did a CT scan, we did an MRI scan. We did not find absolutely anything to explain that. The second patient with the delayed neurologic deficit was this patient with the recurrent fracture after the fall. As I mentioned earlier, we had one cement embolism, which was clinically significant because it resulted in death. And we've recently had one patient who had a same level vertebral collapse. This patient, I was tossing between doing a surgical stabilization or vertebroplasty. I advised the patient that we'll try vertebroplasty. If it doesn't work, then, he's an elderly patient. We want to avoid surgery. But eventually, the patient got good relief immediately post-op, but a few weeks later, he collapsed and again started getting pain. So this is it. Thank you very much. With this, I stop my talk. I am happy to answer any questions regarding the technique involved in doing this procedure. Agnivesh, if there are any questions from the panelists, from the audience, I would be happy to take.
Sir, I will begin by asking one question that do you pre-decide that which cases you are going to do bipedicular vertebroplasty, or you always choose a unipedicular approach? How do you decide?
When I started practicing vertebroplasty, a number of times I would do a bipedicular because I was afraid that the cement, if it's not a pseudoarthrotic cleft, then the cement would get localized to the side on which I am doing the vertebroplasty on. And therefore, I would think of doing a bipedicular vertebroplasty, especially in patients where there was no pseudoarthrotic cleft. I have now realized that even if you inject, even in those who do not have a pseudoarthrotic cleft, if you have injected cement, even through a unipedicular injection, the pain relief is exactly the same. So now, for practically, I do not go for any patients with a bipedicular. The exception is possibly metastatic spinal tumors with pathological fractures, where I may do a bipedicular injection.
And do you sir decide your entry point based on the location of the cleft? Like in some cases, the cleft is inferior. It's a rare situation, but it is. And in most of the cases, it is at the upper end plate. So do you decide your entry point based on the trajectory you are going to take to reach the cleft?
Yes, you're right. I mean, if there is a inferior cleft, then one tries to go as superiorly as possible so that you can incline the needle right down into the inferior cleft. If it's a superior cleft, it's not much of a problem. You can go through your regular entry points without a problem.
Right. Dalvi sir, your comments, questions?
No. I think Gautam explained everything very well. No real difference in that. So as he pointed out, there was a point when we did a few together to help him build his confidence. And so one can say that he's my student. And then he used Manish's videos, and Manish is definitely my student. So I can say that all is good.
Right. Thank you.
Before we go ahead, I'll just
yes,
want to welcome Dr. Pandya here, who's from the MMC as an observer to make sure that we are doing the right academic work. Thank you for coming over, madam. And I'll request Arjun that we can go to the next session.
So thank you very
I
much.
would like to thank the organizers for giving me this opportunity. I would particularly like to thank Dr. Manish Kothari and Dr. Nikhil Arbati, both of whom lent me a few of their slides and pictures for this talk.
So I'd like to invite Dr. Dalvi now, for the next session on percutaneous screw placement.
So mine is a pre-recorded, so I'm hoping that the organizer will play it.
Suvita, can you please play the talk?
Hello. Today my topic is the technique of percutaneous screws. Now, percutaneous screws is something which has become exceedingly popular, and its use has really, really expanded. I think I started doing percutaneous screws many, many years ago, and I presented them a long time ago, even before the systems came in, without the cannulated systems. But now they have become so sleek, and there are so many companies which produce them that they have really become part of our armamentarium, and they're used for a lot of indications and minimally invasive surgeries. Now, my brief today is only to talk about how to insert these screws, and therefore there's going to be a very short video on how to do this based on one case. So this is a 36-year-old unfortunate young man who has a sort of spinal metastasis, and which is affecting his L1 vertebra. But if you saw the previous X-ray, in addition to the marrow change, he also has a collapse. So he has a very severe element of mechanical pain, and radiation was not going to be enough for him. In addition, this was squamous cell carcinoma of the buccal mucosa, and it was not radio sensitive. And he could not even turn or move in the bed. Although his life expectancy is not very high, he needed palliation. And as you saw in the first X-ray, there was also a huge collapse. We've done a PET, etc., and he also has liver metastasis, but this was the only one in the spine. And hence we decided to treat him with percutaneous screws. So this is the operation theater setup. As you can see, it's very, very important to have a proper radiolucent eccentric kind of table because you need to have a free swing of your C-arm. And all of this has to be confirmed before we start the procedure because you can't fiddle around later on. We take this patient on bolsters because it has to be, everything has to be radiolucent around the patient. And your entire setup has to be ready. Obviously, these are screws, so these are done under general anesthetic. Even a normal orthopedic table with an eccentric platform or turning around can be used. You don't need special tables, but you do get Jackson tables, which are very good for these. The next important thing to do is to check the C-arm, even before we do the painting and the draping. And we have to get the C-arm technician in, and we need to look at the images as we would when we are doing the procedure. So unless you confirm this, you should not go ahead with the procedure because visualization is the most important thing. And if you can't visualize what you're doing, you cannot proceed with this operation. So in this, we can see that on positioning, it has opened up a little, not completely, but a little, which is okay because we don't necessarily want to over open it either. And you look at the lateral to see whether you can see the landmarks. And we look also at the AP to see that we can see everything and it's adjusted. We then go ahead with prepping the area. And one of the slight differences I like to point out in our normal draping is that we don't put the IOBAN sort of on the thing because we take a lot of small stab incisions and the plastic will then go inside, especially with the needles. So we sterilize the skin and use the IOBAN to stick the drapes at the side. And we just go through the bare skin. Having done that, again, we check everything that your C-arm is visible. And this side drape is extremely important. The side drape is extremely important because this drape is necessary. This side drape is extremely necessary. It has to be a big, long drape because the C-arm, this part swings up from under the table laterally and it needs to be completely covered at the time of the shoot. Having done that, we then check the implant tray. And again, I cannot but point out, any surgery that you do, you need to need all equipment. But the more minimally invasive and precise surgery you do, even more you need to have extremely precise equipment. You cannot have lack of inventory, and I make sure that everything is there before I touch the patient. So your entire inventory, instruments, etc., because this is a highly technical, instrument dependent operation. So make sure that everything is there. And then we need to assemble the screws. So this is done offline by the company person or by your assistant, where you assemble these screws. So assembling these screws on the external assembly is extremely important. Again, I don't want to say about one company versus the other, but each company has their own method, and you should be familiar with that, or the company person should be there to be familiar with it. And at the end of it, your screw should be held well. Your screw cannot fall off during the middle of the procedure. So it should be rock solid. It should not move. And your whole assembly should not give way when you're actually putting in the screw. And you have to make sure that the guide wire goes straight through this. I think, again, without taking names or anything, the Indian companies, you have to be more precise. The foreign companies usually are good enough. Then we start the procedure really. And identifying the pedicle is very important. And it is always done in the AP. This is how the C-arm is draped, with the big box on top and the other thing below, because we swing the AP and the lateral from under the table, not from over the table. Now, you have to be able to, you need to tilt the C-arm in such a way that you can see that vertebra as a beautiful vertebra with its two eyes and its beak, and the end plate should be parallel. So for that, you may have to tilt, especially if there's a kyphosis or a lordosis, you may have to tilt it this way or this way to make sure that you get a proper end-on view. And your skin incision has to be accordingly projected. Because if you keep, if the patient has a kyphosis or a lordosis, and if you then tilt, if you keep your C-arm straight, your skin incision will be at a different place and your screw will be oblique. So having done this, you mark on the AP the sort of entry points for the screws, or it's not the entry points for the screws really, it's the entry point for the wires. And you need to, you can see, as you can see, you tilt this till you get a proper end-on view, because there's going to be some kyphosis or some lordosis, and you have to be sure of that. Again, you visualize all of these and you mark them. And I then use infiltration. I like to use a sensocaine, lignocaine, adrenaline combination. The reason is that it gives sort of bleeding control and less reaction to the procedure. The patient is in a with the analgesia, and post-op also these patients have less pain. So some of that I'm used to infiltrating these patients before doing the surgery. This also gives me a second chance to look in the AP and the lateral as to my positioning, as to where my skin incision is, because otherwise I might be off by a particular amount, and I do that. Then comes the stab incision. Initially, I take a small stab incision to put in just the Jamshidi needle and then extend it, because sometimes you may be off, up or down, and you don't want to have excessively long scars, because one of the aims of the percutaneous procedure is cosmesis. Another side note, I keep the foot pedal of the C-arm with me, and it has two modes. It has a screening mode and a shooting mode. So you need, the screening mode has less radiation than the shooting mode, and the shooting mode will but stores the image. So accordingly, I use the left or the right pedal depending on what I want to do. So the initial stab incision is very small, just enough to put in your Jamshidi needle, and you need to also cut the fascia, because otherwise it gets stuck. And then comes this important part where you put the Jamshidi needle. Now this is extremely similar, especially if you're used or experienced in vertebroplasty. This is very much similar to a vertebroplasty, except that your margin of error is less here, because your screw is going to be placed here. It's not just a matter of injecting cement and getting out. You're going to be putting a screw. So you have to be very precise. Usually you tend to enter slightly laterally so that you can converge the screw. If on the C-arm, you put it at the same place where the pedicle is, your screw will go straight. But if you start little laterally, then it should hit the pedicle entry where it hits the bone, because there's going to be a depth of tissue in the bone. So this experience tells you, and then you do this and you look at the, so that's what you're looking at now. So if you can see, now my needle is docked over here, and this is the pedicle, and I've docked really at the superior and lateral part of the pedicle, which gives me a good sort of inclination to converge this screw. And at this point, we are really just at the tip or at the entry, and you dock it on the bone. And sometimes in degenerative spines, it's not easy and it keeps slipping off. So you need to tap it a bit to make sure that the sharp tip sort of engages it. This also gives you an idea that you are in the straight line. You see, you are going to, in this projection, continue in the correct direction, right? And having done that, you advance, though of course this is the lateral projection, I advance it in the AP projection. So you do in the AP projection. Now here comes the key point, which is true for vertebroplasty and screws, which is the biggest key in these procedures. It means that you have to see the outline of the pedicle, and the tip should not cross the medial border before it crosses the posterior border in the lateral view. So that's very important. So this is just so right. So this image, if you see, the tip is exactly at the posterior border of the vertebra. And if you saw the AP X-ray, at that time, it had not yet crossed the medial border. If it crosses the medial border, means you have got a medial perforation and you are in a soup and you have to start all over again. So now this is going very well. Once you've done there, you can then go in the lateral, because then the AP has no meaning. And I usually go ahead and I do half to 2/3 of the vertebra. I don't go fully ahead because of the way the vertebra is shaped. We don't want to specifically go and pierce the anterior cortex. Placing of the J needle so far is very similar to vertebroplasty, except that it has to be more precise. And you then take out the sort of the stillet, and you again confirm it, of course, in AP and lateral C-arms. And then you put the guide wire. So this guide wire is very important. You need to test the guide wire preoperatively as well to make sure that it's straight, it's not bent, it goes through, it's not going to break. And most of the companies have a serrated tip at one end or a threaded end and sort of a smooth end. And I like to put the serrated end inside, because what happens is that otherwise it can just slip out. So I put the serrated tip inside, and you have to go slowly, because sometimes you can just perforate and go anteriorly, and do it on the C-arm. And having put that, you then take out the J needle. So unfortunately, this PIP C-arm is showing it without the J needle, but that is where the guide wire sort of lies. And once it's in, you can now see, this is very important to get your assistant to hold the wire. So one of the biggest problems in doing a percute screw is the wire slipping out or the wire advancing in. So both of these are problems, and therefore your assistant must have control of the wire during all of this. So now I've got my assistant to hold the wire. He should not push it in too much because it can perforate anteriorly. He should not allow it to pull out. And with rotatory movement, sort of, because the bone may be hard, especially in a young patient, you know, and you take it out. So you can see I held it at the top and then held it at the bottom and made sure that the wire is there. At every stage, it's better to do a C-arm to make sure that the wire is there. Now, this is the dilator where you dilate the tissues. And at this point, you may need to extend the incision. It is not good to stretch the skin. It is rather better that you take a skin incision which is slightly larger, because if you stretch the skin during this procedure, the skin necroses and gives rise to an extremely bad looking ugly scar. Whereas if you just take a smooth incision and suture it, the scar is not visible. You put in these dilators to dilate the soft tissue and make sure that they're all the way down in the C-arm. And then you take out the inner dilator, and the outer dilator acts as a sleeve for the tap. So this is the tap. Now again, different companies have different instruments. If the tap is blunt, then some companies have got a sharp awl to make the entry point, and you need to use that, because otherwise you can't enter. What happens is we are going blind. We are not seeing anything. All of you who put screws in the open method know that we use a nibbler or we use something or a drill to score the entry point, but here it is not so. So, and the diameter of the J needle is much smaller than the tip of the screw. So you don't want to have issues. So you put in a sharp awl, or some people have sharp reamers to be used, or in some companies the tap itself has a sharp tip, as in this company, where I'm directly using the tap. So you use the tap. Again, this is done under C-arm control. As you can see, making sure the CM controls a few things. Number one, you need to look where the tap is going. But number two, you also need to look that the wire is not advancing, because if the wire gets stuck in the tap and it advances, you may have a big problem. So you need to make sure that you do this step under the CM. Again, while taking it out, if you see, you take out the tap, you have to make sure that the wire doesn't come out. I keep stressing this, but the wire moving is one of the biggest problems in doing percutaneous screws. So what you do is you take the tap out, then you take the sleeve out, and you hold the wire below it and then pull out the whole assembly together, making sure that the wire remains there, and check it. And then putting the screw becomes very simple. It's a percutaneous screw. You just need to go from the top and push it in. Again, unfortunately, it is radiation, but you cannot cut it. You have to do it under intermittent CM guidance, because the biggest issue is, again, the wire being pushed in front. Sometimes because the tip of the wire bends. And usually when I'm beyond 50% like this, I pull out the wire because the wire is not required anymore. And then you push down the screw till the tulip sits well. And you need to get a good solid feel. At the same time, it should not be so hard that the tulip is completely fixed. Because if the tulip is completely fixed, then the tulip cannot move, and then it becomes very difficult for you to seat your rod. And in fact, previously when we were doing this with systems without jigs, so I've done some of these without jigs as well, we actually used to keep the tulip slightly out to make it easier to put in the rod percutaneously. Of course, with the jigs, that's not a problem. So you can put in the screw in a normal position, but don't put it in so hard that you can't move the tulip after that, because otherwise you won't be able to seat the rod. You then do the other screw, as in this case we are doing the other screw above that. So it was L1, so we finished with L2, and now we are doing T12. As you can see, this is a thoracic one. So I'm using a slightly anatomic screw, slightly pointing down screw. It doesn't matter, but if the screws, all 4 screws are totally parallel, it's not good. You can get a parallelogram effect, and a little lack of parallelism is always good. The technique is the same. I put the J needle, I put the wire. Now I'm putting the tap on top of that, and then putting the screw. Now the next stage, as you can see, the screws are put with both the assemblies outside, and the next step is to measure the rod. And again, the companies have a similar device to measure the rods, where you put in this device inside, and there's a vernier caliper kind of system outside where you measure it. Now measuring the rod is very important, because the last thing you want to do is put in a short rod, because the short rod is not going to work, and a long rod will look bad on x-rays, and second, it can damage other facets. So getting a precise rod length is very important. Now through 1 above 1 below, it's not a problem, but when you have something like a longitude where you're putting 4 screws, 5 screws, 6 screws, the last thing you want to do after a struggle of putting a rod is finding out that the rod is not the right size and taking it out and having to put another one. Now this sort of device is there to cut the fascia, to be able to put in the rod. It's a curved scalpel which you put in the slot, and you cut the fascia just above the screw tulips to make sure that the rod goes. And then this is the device which you use to put the rod. So here again, there are different systems which have different devices and different ways of putting them. And this is one particular company where the screw, the rod is mounted on this sort of a freehand handle, and it is put in through the slot and guided in. So this is also the same thing for one where you have more than 1 screws, but some of them have different systems where it goes through both the screws and then you can tilt it in. And one of the companies has a sextant kind of device where it is directly guided in through through another incision. So the negative of that is that there's another incision, but the positive is that it's guided very well. So here it's a lot of feel. You have to have a 3D sense of where the rod is going, because there is no jig for it. You're just putting it with this, and you go into the slot and try to push it down and try to send it through the other one. And what is important here, when it goes, you get a feel of it hitting the other screw. And we also use the CM at the same point to make sure that we are over there. But of course, the CM is in one plane, and you may be missing it medially or laterally. And that is where your sort of psychomotor skills come in. And we try to push it through. And once we push it through, how do we know that it is in? We try to rotate the screw. And obviously, if the screw can't rotate, it means that the rod is inside. As you can see, I'm trying to rotate it. And the other thing what you do is you have a sort of a screwdriver which you put in, and then if it hits the rod rather than goes into the tulip, you know that the screw is right. and then you can fix in these nuts. Again, different things have different systems, but usually inherent in the system is a reduction device by which you can reduce the rods into the tulips. You need to tighten it fully. So these are finger tighteners. So this is not rock solid. These are only finger tighteners by which you go in and tighten the assembly, and you need to again take it out. Having done that, of course, I should say that you need to check everything on C-arm. Don't not check things on C-arm. Then these are now the final tighteners, which will give a larger tightening to the nuts. And this is tightened quite well. And following this, you do a torque tightening for that. And for torque tightening, the most important thing is an anti-torque. So you need to have an anti-torque device, because otherwise your screws will come out. I'm now disengaging the rod holder, and that too, you need to take it out and tilt it. And now I'm using this anti-torque device, which will prevent the screw from spinning out. And it has a special slot in it to prevent it. And we put in, so this stabilizes the assembly. And then we have this torque loaded device, which has a fixed torque in it, and we have to do it till there are 2 clicks. Again, this is pretty standard, but this is very important to do, because if you don't have the torque tightening or the screw skives off, then you know that there is something wrong. Again, you need to look at everything under the C-arm to make sure that things are right in place. Having done that, we take off the top assemblies, and that kind of completes the procedure. And we then take proper AP and lateral shoots to make sure that everything is in place. So you need to be sort of familiar with the system which you're using. Unfortunately, there are a lot of systems, and many of them have their own quirks, and many of them are different in their own way. And at the end of the day, you need to be comfortable with 1 or 2 systems which you use. And of course, the person, the company representative is very important, because they really do know their system pretty well. And there are some quirks here or there which may be necessary for them to know, for you to get out of tricky situations. So some of the serious problems which you face are, one is like I keep mentioning about the guide wire, because either the guide wire going in and damaging something, or the guide wire coming out and you have to start from scratch is a problem which can delay you. The other issue is the screw disengaging from the external assembly. That's another huge problem, because once the screw disengages from the external assembly, it becomes very difficult for you to guide your rod. And another problem is the rod getting disassembled from the rod holder inside, because if the rod separates from the rod holder, you don't have control, and then you end up having to dig a lot to get that rod out. And believe me, it's not easy. So you have to make sure that your rod is well connected to the rod holder when you're inserting the rod. So these are just 2 tiny incisions, and we've done the fixation. One side fixation is over. In this patient, we also needed to do some other stuff. So we also did a sort of a biopsy for him. So, we put in another sort of, you can see J needle there, and we've done a sort of biopsy for him as well. And so that completed one side along with the biopsy. And of course, this didn't complete the surgery for this patient. We also did a vertebroplasty from the other side, and then did a fixation from the other side as well. And this patient's mechanical and other pain was completely relieved post-op, and he's comfortable and doing well. As we know that he's a poor young guy with bad metastasis, so he has a limited life, but that life at least will now be hopefully painless. So friends, that sort of completes my talk on the technique, and I'm sure there'll be many questions. And in just this lecture, we are not able to cover everything else, so I'm happy to cover everything in the further question and answers. Thank you very much.
Thank you, Dr. Dalvi. So I'd like to ask you, what any tips in a longer construct with respect to contouring the rods and measuring the length, because if it's a longer construct, sometimes that can be challenging.
Yeah, so definitely. I mean, I think in your learning sort of curve, the longer ones should come later. Initially, you start with 2, and then you maybe go to 3, and the very very long ones is going to take time. But the rods there have to be measured by CM, and you can sometimes get it wrong. But those the ones which require very long constructs are those who have bad pathologies anyway.
Correct.
And you have to make sure that your screw heads are in one straight line. Otherwise, it becomes a big mess. So it's a whole lot of experience, and I think those who there is very little which I can tell you in terms of it's you make it up as you go along. But I think start with 2, then go to 3, and only then you think of doing the long ones. One of the things is don't try to put too many screws very close to each other. You keep gaps, like have D5, D7, D9, D11. Don't try to do D4, D5, D6, D7, because that's going to be even more difficult.
And in osteoporotic patients, any tips sort of, because of the backout risk, which is, we're not fusing really. So
I have not done it, but theoretically speaking, there are these fenestrated screws through which you can put cement in them. Even the percute screws now get fenestrated. So I have not latched onto that for whatever reason. But I sort of look at the overall biomechanical construct. So if it's osteoporotic, then I would do screws plus vertebroplasty. So reconstructing both the columns.
Thank you very much. I'd like to invite Dr. Agnivesh now for his talk on robotic screw placement.
Hello, everyone. Thank you, Bombay Spine Society, for this opportunity. And we'll discuss today the role of robotics in minimal invasive spine surgery. The question arises that why do we need a robot? Now, I would like you to have a look at these graphs, look at the shapes which have been cut out. You'll see that none of them is a perfect circle. They were intended to be, but the human hand has a limitation. Whenever we plan to do something, there's a plan and action analysis. If your planning is adequate, your action is intentional, that is when your outcome is a success. Otherwise, it leads to an error. Now, human error can be a skill-based error or a mistake. The robot does not correct a mistake. It takes away the human error. The Miser Renaissance guidance system was released commercially in 2011 and was believed to be as accurate as 1.5 mm. And today we have new generations robot, which are free robotic arms and giving the same trajectory and giving the same accuracy. Now, I would just highlight the rule through cases. And this is a 54-year-old male with severe low back pain and claudication radicular pain, 2-level stenosis, planned for L3, L4, L5 decompression and instrumented fusion. While on the robot, you need to plan the surgery. You need to do the segmentation, that is identifying the levels, check them in the axial, lateral, and AP plane, and plan your screws accordingly. And you check them for any breaches, any migrations, and you have to do adjustments till you are satisfied. The next step is to put a clamp in a central approach onto the spinous process and take a AP and a 60-degree oblique view. And you label these vertebrae, and robot does what is called as fluoro-CT matching. So only if there is an accurate matching, then it will allow you to go ahead. So in a conventional method, the robot is placed on a spinous process clamp, and this is what we call as a bridge. And you let the robot sit on the bridge and give you trajectories. You have to drill holes and put guide wires over there to be drilled later on by the tap, and you insert the screw and get the perfect execution of your plan on table. Another case where there was an extruded extraforaminal disc causing severe radiculopathy and back pain. And this was the typical problem of a crest overhang. And you can see that this is how much it is overhanging into the placement of the screw trajectory. So this is what helps you in analyzing preoperatively and planning your trajectory and getting rid of what a potential medial breach could be, as I would also highlight in a subsequent case. And this is 3-year post-op. very minimal scarring because there's very minimal retraction. Now, another 60-year-old male with degenerative spondylolisthesis planned for a TLIF. So you do a small exposure, place the bridge, and the robot gives you the complete information, what arm, which side, and which cannula to use. You use those, drill them, and place your screws in the minimal invasive fashion way. Now, if you don't want to do the the central approach, you want to spare the central, then there is a bridge which you can fix onto the iliac bones with 2 shank pins, or you have a special clamp which gets attached to the side of the table, and the robot sits on this T bridge now and does the same job for you, what you were doing with the conventional approach. And what actually is happening inside is that as you are going ahead, the robot is giving you the trajectories sequentially as the planning, and you drill the pedicles and replace them with the guide wires. The next steps are the same as any minimal invasive implant fixation or the screw placement. You tap the holes and put in your implants. Now, another interesting case which was done in long years ago by a minimal invasive technique, and the patient had achieved a good fusion, but the patient had a breach of the right-sided pedicle, again because of this overhang of the crest, which drives your screw more medially. Now in this, we were able to salvage the situation by using the same pedicles, but in a different trajectory, intersecting the old trajectory at one point and going in a different direction. And this is so easy and so easy with the robotic guidance that it is almost effortless, because you are as drilling a new pedicle and you're not worried about the old hole is going to come in your way and your instrument is going to slip in the old hole. And this is the final outcome. Again, the lower screws were removed. They were not serving any purpose. And beyond the degenerative, there are other things which robot helps you to achieve. It even helps you in scoliosis, but I'm not discussing that today. I am discussing if the pedicles are very dysplastic, it helps you to put in approach screw very easily in a minimally invasive fashion way. You can mark the bone tumor margins or your resection margins by the guidance system, and intraoperatively it's very easy to sort of end your surgery where the marker wires are, and sort of you will be more confident in ending the surgery at that level. It helps you to put S2LR iliac screws, again minimal dissection, and you don't have to take too many radiographic shoots. Minimal invasive sacroiliac fusion, which we know under fluoroscopy is a challenge because you need to avoid the S1 foramen on one side and you need to avoid the canal on the other side. So it helps you to even do that. And one of the best things is the ProLat procedure, where if you have done an anterior surgery, XLIF or OLIF or anterior surgery, and you don't need to flip the patient over in the lateral position, the robot will give you the SS to put the minimal invasive screws, and your time and effort is saved in repositioning the patient. Now, I would like you to see this video wherein a robot is solving a Rubik's Cube in fraction of a second. The fastest time by a human is 4.7 seconds. Now, this is way, way faster than a human hand could do. So this is the beauty of the machine, that it can work much faster and overcome the limitations of a human hand in a much better way than we can do. But the patient care is in our hands. It executes what we plan more perfectly than what a human hand could do. Thank you very much.
Thank you, Agni, for a nice talk. So, I'm going to objectively sort of involve some of the faculty here. So, Agni, Manish, the younger guys, and Satyen and Vishal. So, versus, robotic versus navigation, versus freehand screw placement, is there really a difference? So I'd like to let Agni start off, with Manish, and then have some inputs from Vishal and Satyen.
So if you're saying freehand, you're referring to open technique.
Yeah, I mean,
Yeah. So the studies have shown that robotic placement is better than human hand, almost by 10 times in case of implant malpositioning. They may not be symptomatic, but yes, it increases the accuracy. So accuracy wise, safety wise, and then there are certain limitations like with the robotic assistance, like you can mark the tumor margins, the sacroiliac fixations and all, they are much, much more easy in the C-arm. It increases the safety profile, it reduces the effort, and especially in minimal invasive, it reduces the intraoperative C-arm exposure to sort of do that initial step of marking the pedicles and putting your Jamshidi needle in.
Manish?
Hello. Yeah. Thank you, Dr. Arjun. So, of course, robot and navigation makes a difference, and there is definitely a case to use it, but it will only be available, as in, it will be very, very useful in the like 1 or 2% of your cases. Most of the 97, 98% of the cases, a C-arm is good enough. But as I learned from UK, Nottingham, we used to use the O-arm very frequently there. To do those difficult cases and execute those difficult cases under a navigation O-arm, you need to have yourself, your entire team, and everyone well versed with the system. So you have to keep using it in your simpler cases so that the use becomes easy. So definitely it has a role.
So Vishal, what do you feel? Is there a cost benefit ratio really? And I mean, you're doing large numbers, you have experience with navigation, freehand, and so I'd like your comments on this.
So I think there is no doubt that technology has always evolved to make the surgical precision better over a period of time. We all started with C-arm, we went into navigation, and now is the era of robots. But I would also say that on one hand, robots add to your precision, but they have their own pros and cons. Navigation, I've been using it in lumbar spine, in MIS, in cervical spine, in thoracic, in scoliosis, and it has really changed the way we used to do our surgery 5 years ago. And today we have far better precision, and I am sure robotics will change over a period of time. But today, I think robotics are in a very, very, very infantile phase of evolution. And I think it is time that we as surgeons embrace the robotics and various technological advancement in implant placement, not only to learn the technology, but also to tame the technology so that tomorrow, when the time comes for these difficult cases like Agni mentioned, for sacroiliac fixation, scoli, cervicals, complex deformities, all those things, I think human hand definitely has a lesser role in terms of getting a precise screw placement. And I'm sure technology so far in terms of navigation has helped, and I'm sure robotics will further add to the precision. But today, I think not only cost benefit analysis is not in favor of robotics, it is not even in favor of navigation for simpler cases. But it is a time to embrace this technology. It has helped and paved the way for modern surgeries in other branches. And I'm sure spine also will see the same day as the time evolves. So don't just refute the benefits of robotics and navigation. It is time to embrace this technology for the future.
Last words by Satyan, please.
I actually wanted to ask about 2 points in this when we are doing robotics. In trying to get to a perfect positioning of the screw, you may often violate the facet capsule and cause the adjacent segment, early degeneration. Is that an issue with this? Number 2 is with an extra incision with extra equipment being all around. Is there a higher chance of getting an infection? And are there any studies on these?
So regarding the first point, Dr. Satyan, the robot typically, whenever you plan the screw, there is a way to sort of enter your trajectory. It has to be at an angle in that recess of the lumbar pedicle and the lumbar facet, which is away from that capsule area. The reason why we do that is there is something called as a tool skiving. If you plan your trajectory sort of at an acute angle to the facet, what happens is when you're drilling in, it just sort of deflects from the facet and goes extrapedicular. So you have to purposely do a bit more angulation so that you are into that recess at 90 degrees. Second is that you've seen the tip of the Cook's needle. It is like a serrated sharp thing. So there is a special instrument which goes inside the protection sleeve, which is the drill sleeve, and you have to hammer it with a gentle 1 or 2 taps into that sort of bone so that it locks itself in. So it doesn't so it is at a recess which is almost extra capsular. So that thing, that violating the facet, is sort of a remote possibility unless you are misplanning your screw. And one more point regarding the cost benefit analysis. Yes, today it may be a bit difficult to justify it, but again, we all know mobile phones 2 decades ago were sort of a luxury, and today they are sort of in everybody's hand, and in less price than what it was at that time. We have more functions. So I believe as the time evolves, it will get cheaper and more people will have access to it.
So Dr.
So,
Dalvi,
if I can say something about
Yes,
this
please.
robotics and navigation and all these newer technologies which are coming up. So I think it's a natural evolution of things. But what this technology does is that it works on making people weak. What do I mean by that? I mean that 20 years ago, I would remember all my friends' phone numbers, but today I don't even remember my kids' phone numbers. Why? Because everything is the technology. So I cannot do a simple calculation because everything is there. I don't need to remember anything because I can Google everything. Today, I know how to put screws by feel and by looking and by the anatomy. But the next generation will not know even how to do that because they will only know how to do it by navigation and robotics. And what will then seem like a necessity. So I can imagine 30 years later, people saying, oh, in the past, people used to put freehand. They were in the Stone Age. But the point is that these guys are not skilled. The new guys are not skilled. They will not have the skills of how to do a proper surgery. Rather, they are just dependent on technology, and then they are made lame. So that is my comment about this. And I personally, if you ask me, especially in the spine, these are unnecessary, expensive, complex, complicated technologies which increase the complexity of the procedure, but they do not translate to better patient outcome. Where the patient outcome is based on case selection, it's on execution, on on actually understanding the natural history of the spine, and none of this does anything else except get us maybe better looking x-rays with less radiation. So I think it's we need to really look into ourselves as to whether this is translating to better patient outcomes or is just we're just making things more complex and more expensive. So fine, that's the way everyone is going, so we'll go like as Vishal said, because if we don't go in that same boat, then we'll be left out. But the fact of the matter is this, that people will get de-skilled. They will not know how to do it properly.
Yes, Vishal. Thank you, sir, for your frank and honest feedback. And
not to counter Dr. Sameer's word, but I think what he emphasized, what he's trying to make a point is that these technological advancements come into picture only when the basics are there, because these machines, they don't make you smarter. They can actually make a fool out of you unless you tame these machines, and they are meant to supplement surgical skills. That means the surgical skill is the primary thing, and I am sure all the fellows are going through the same training process where basics are taught to them before technology is taught to them. And I think that's how the training program should evolve. So this is absolutely mandatory that the basics should be learned very well before jumping into technology. But on the other hand, the advantages of navigation, robotics, 3D imaging are not something that one can neglect. That there are obvious advantages. If MIS, Dr. Sameer just showed us about percutaneous pedicle screws, and he spoke about the advantages of this. The advantage of adding navigation and technology is further not only adding precision, reducing radiation, but also expanding by having wings to your indications. Now, today I have been doing complex craniovertebral junctions, which I would have never dreamt of by doing without navigation. So I can actually stop at OC2 when I'm dealing with a basilar invagination with a complex C1, C2 deformities. So those are the issues where navigation, robotics, and O-arm and 3D imaging definitely plays an important role. And I would never have been able to do a navigation in CV junction unless I have learned to use navigation in the basics in lumbar spine. So as we evolve, your wings become broader and bigger. But yes, these all technological tools are meant to supplement surgical skills, and this cannot be overemphasized here.
so I'm going to ask Agni to give in his last comments to refute anything. And I mean, it is a fact that screw placement is more accurate with navigation. We have looked at this objectively in a series, and we found a 25% malposition in children with the freehand technique. So it's actually how you review your data also, because as they say, there is a difference in symptomatic and asymptomatic screw placements. So
Right. I just want to make one last point that, as I said in my slide, that all these things, navigation, robotics, they reduce the human error. They don't correct the mistake. If sort of in an osteoporotic spine, you're doing one level up, down fixation and it fails. So it's a mistake on the part of the surgeon. So it can reduce an error. It doesn't correct a mistake. So that is what and again, you need to go from the basics. Somebody who doesn't know how to put a freehand pedicle screw should not put a navigation or a robotic screw. You can't have a jump in the learning curve.
Thank you. I think so. I think the surgeon experience matters. I think that's really where we discuss it and looking at everything sort of in in perspective. So with this, I'd like to sort of hand over to Agni to start the next session. Inviting Vishal.
Yeah, thank you, Dr. Arjun. So I would like to invite Dr. Vishal Kundnani for his next talk. Dr. Vishal Kundnani is a senior spine surgeon from Bombay Hospital and Leelavati Hospital.
Just give me a minute, please. Yeah.
Please allow screen sharing with Dr. Vishal Kundnani. He was just talking about C1, C2 stabilization using navigation or robotics, etc. And this is what he will be showing us, a surgical video on C1, C2 minimally invasive fusion techniques. So he's a proponent of a trans-articular C1, C2 stabilization. Over to you, Vishal.
Thank you so much, Satyan. I again congratulate the whole Bombay Spine Society team for organizing a wonderful meeting. And this BOSC, Bombay Operative Spine Course, has been very close to my heart. We are entering into the 8th year of BOSC. And yes, this topic, transarticular screw, is another thing that is extremely, extremely close to my heart. So we all know that C1, C2 dislocations are not uncommon. The more we see our patients, the more we are able to diagnose them. And the crux of the matter in C1, C2 dislocation is that most of them actually will not have neurological symptoms to present with. So please do not just decline a neck pain patient and just treat him like a spondylosis, because most of these patients will actually have only neck pain as the presenting symptom, or they may actually be asymptomatic, particularly in patients with rheumatoid arthritis. In fact, in kids, a subtle torticollis can be the only presenting sign in patients who have a hidden C1, C2 dislocation in such patients. And that's why a critical appraisal and evaluation of all such patients is absolutely important, to extend that sometimes when you see that the rotation is restricted, do not hesitate to do a C1, C2 evaluation by doing dynamic films flexion extension, and you will see surprises that in 20% of times your neck pain may actually be coming from a hidden C1, C2 dislocation, which on a normal standing lateral X-ray may not be seen actually. So this is something that we must all may pay attention to if you really want to catch them early, and it is absolutely important to catch them early, because the diagnosis and management will become easier if you really get them early in the course of their natural history. Now, C1, C2 fixation techniques have been described in detail. We all know there are segmental techniques, and transarticular is another one way which was described classically by Magrel's Neo technique. And there are various pros and cons. We won't go into the details of it, but today I think with higher fusion rates, extremely rigid fixation, this is something that I would propagate, that transarticular screw is definitely a gold standard if it is possible to do in such cases. C1, C2 fixation with transarticular screw still remains the gold standard if it is possible to do in such cases. Now, what is transarticular screw? It is nothing. It's a screw fixing C2 to C1, passing through the joint of C1, C2. And the whole trajectory involves passing from the C2 lamina, going through C2 pars, going through C2 isthmus, coming out of the C2 articular process, entering into the C1 articular process, holding the C1 lateral mass. And this whole fixation of C1 to C2 through the joint is trans-articular screw fixation of C1, C2. And the best part is that this is the only technique which has so far shown 100% fusion rate with absolutely nil implant loosening of the screws, at least in our series so far. Now, 90% of transarticular screw surgery is nothing but preoperative planning. Now, if I have to tell you that one thing that you must do is that plan this surgery so meticulously that 90% of it gets done completely preoperatively, even before you wash up, even before the patient is anesthetized. And this is easily doable. It is easily possible. And the downside of transarticular screw that people feel or propagate is that it is a risky surgery. It has more vascular problems. It is not possible at times. Take my word that if you are meticulous in your preoperative planning, not one case you will not be able to do a transarticular, even in patients with high riding vertebral artery, dysplastic anatomies of C1 C2 joint. I think I have done everything purely based on this one thing, emphasizing the need of pre-operative planning. And it can basically be divided into only 3 steps: feasibility, reducibility, and trajectory. Let's take this one by one, and then we'll go on to the surgical technique of it. What do I mean by feasibility? Now, the first thing when you plan to do a transarticular screw is rule out contraindications, whether it's a irreducible AAD. Now, what do I mean by irreducible AAD? Only those atlantoaxial dislocations which have a bony block to prevent the reduction of C1 on C2 are the ones where transarticular screw is not possible. Other than those, there is not a single case where C1 cannot be reduced on C2. It may actually require joint distraction. It may require arthrolysis. It may require a push of C2 from behind, or it may require a push of C1 from the mouth. All these maneuvers of reduction should be tried. In fact, 60% of times, a simple looking irreducible AAD may just reduce the moment you give anesthesia to such patients. And that is what is the importance of examination under anesthesia, because most of these patients which look irreducible in the wards, despite giving best of traction, may actually reduce the moment you just position them. And that is why always, even before you plan to do a occipitocervical fusion or something that is a bigger morbidity surgery, try to have an examination under anesthesia, or at least keep the armamentarium for C1 C2 transarticular screw fixation ready on the table, because you may be lucky that the simply looking irreducible one may actually reduce, not only just by positioning, examination under anesthesia, or by simple maneuvers that I'm going to highlight now in my coming talk. Now, the second point that is very important is that in patients with high riding vertebral artery, again, this is a very vague term. Till day, there is not a single definition to describe what is high riding vertebral artery. In my definition, high riding vertebral artery is only called high riding when the pars diameter gets reduced less than 2.7 millimeters. If the pars diameter is more than 3 millimeters, it is absolutely making no difference to anybody's life whether the vertebral artery is riding high, is placed laterally, is placed superiorly, or it's placed dorsally. If the diameter of the pars, which is this, the minimum diameter of the pars is 3 millimeter or above, it doesn't make a life of difference to do a transarticular. It is easily possible. However, if you see that the minimum diameter of the pars is less than 3 millimeter, please do not attempt transarticular screw, even when there is no HRVA seen in your CT scans. And that is why preoperative planning, doing CT scans in such patients is extremely important. In fact, to extend that, in initial 25 cases, I would recommend always do a CT angiography. You may meet surprises by seeing anomalous vertebral artery in the C1 C2 area, where your dissection is going to come across and resulting into disastrous vascular issues. So preoperatively planning them by having images, CT scans or CT angiographies is extremely important. And one another fact, because often C1 C2 dislocation is found in adults, and there is a thoracic hump there. So if you see there is a thoracic hump, the cervicothoracic junction is quite kyphotic. Again, you may not actually get the acute trajectory that you want for a transarticular screw to be placed. And again, this can easily be picked up pre-operatively. Like in this patient, there is an easy trajectory of C1 C2 fixation. However, in this patient, the trajectory required may not give you the planned trajectory to get a transarticular screw from C2 to C1. So these are some things. First things, rule out the feasibility, whether it is possible to do or not, whether the pars diameter is more than 3 millimeters or not, whether it is reducible or not. If it is irreducible, there is a bony block to prevent the reduction. You should not attempt a transarticular. You may end up having problems, and the frustration will lead to a disapproval of this as a procedure at all for C1 C2 dislocations. Now, we have published this, we have studied this in our literature, and we have evaluated not only on CT scan, but also in anthropometric evaluation on cadavers as well. We have published this on more than 200 pars of C2, that if the pars diameter is more than 3 millimeters, you can easily do it. In fact, to extend that, in 93% kids less than 8 years of age, the C2 pars diameter is more than 3 millimeters. So earlier there was a notion by Neo et al., where they mentioned that 23% of the general population has not got the feasibility of transarticular screw. Is a wrong notion. Today, only 7% of general population may not be fit to have or accommodate the screw of 3.2 millimeters. 93% can easily accommodate a screw of 3.2 millimeters, because most of the pars, even in kids of less than 8 years of age, is more than 3 millimeters. So this is something that is very critical and a very important carry-on message, that pre-operatively determine that the pars diameter in the parasagittal images is 3 millimeters or more or not. If it is reducible, you are surely ready to perform a transarticular screw. Now, another thing very important is that transarticular screw, you can only see the dorsal edge of C2. You cannot see the pars, you cannot see the C1 lateral mass. And that is why absolutely important to have a true lateral image pre-operatively on your imaging to see, not only on CT scan, but also you want to see what you're going to be seeing intraoperatively. And this diameter can only be seen in a true lateral image. Like here you see, this is not the true lateral, this is the true lateral image. And unless until you get a true lateral image, both pre-operatively and also intraoperatively under C-arm, that means your positioning is not correct. Remember, you're going to be fixing them. The C1 will be fixed on C2 in whatever position you fix, the implant will lie there. And that is why it is very important that you get a true lateral image intraoperatively also to avoid any torticollis while fixation. Otherwise, you would have fixed the C1 rotated on C2. And though you may not have any neurological issues, but the cosmetic issues of torticollis may really screw down your results down there. So this kind of picture intraoperatively and also pre-operatively is extremely important. And this is something that you must emphasize upon while doing planning for such patients. Now, contraindications we just spoke about, indications we just spoke about. Reduction, as I said, examination under anesthesia and positioning. This is something that is extremely important, that on one hand, your eyes should be free of any pressure. On the other hand, the whole reduction comes when your head is lying on the forehead. So it's the frontal eminence that should be lying on the horseshoe, and the military tuck position, where the soldier tuck position is something that allows you not only to pull the C1 back on C2, giving you a good reduction, and examination under anesthesia, or push on C2 or push on C1 transorally before you position the patient prone, is something that will help you to reduce the so-called irreducible dislocation. In my experience, till date, there is not a single irreducible C1 C2 dislocation. Mind you, I am telling you that if there is no bony anomaly at C1 C2 junction, there is not a single irreducible C1 C2 dislocations. I have averted OC fusion in almost 90% of my cases if there is no bony, and I am going to show you some cases which otherwise would have been a OC fusion candidate have been converted into a transarticular screw, and purely by pre-operative planning. These are some ways how you can reduce a irreducible C1 C2 dislocation by putting a wire on the C1 and pulling it while pushing the C2 ahead in prone position, or you can do a push C2 pull C1 technique, or even before positioning, what sometimes I do is prepare a patty and on a coccus or with the help of a thumb, just push the C1 arch or transorally under C-arm guidance, and you will see that the moment you push the C1, the whole C2 falls back and C1 C2 becomes a completely mobile thing. In fact, this is what has been emphasized in Wang's technique also, that you must try all these before doing a Wang's transoral release, because the transoral release is the last resort of reducing a soft tissue contracture, which is contributing to C1 C2 dislocation. And that is why all these maneuvers should be tried. And while I'm saying this, there is not a single case where I have had to convert a C1 C2 fusion into a OC fusion pre-operatively. Now, all this is extremely important, because not only you have to do this while in pre-operatively, but also intraoperatively, all these maneuvers should be kept in ready and kept in mind before planning to do anything bigger than C1 C2 fixation. And this comes very handy when you do a transarticular screw fixation. Now, feasibility has come in, reducibility has happened. Another very important technical aspect of surgery, again, as I say, 90% of surgery is pre-operative. This component is the 45% of the surgery. Now, in Masashi Neo et al. Classification technique, what they mentioned is a fixed entry point, that you have to always start at this green point, and go from down upward laterally. However, what we emphasize in our technique, and we have published our data on this, is that the entry point is tailor-made. The exit point has always got to be fixed. It is the exit point which cannot be compromised, and your tip of the screw, the end point of a screw, should always be in zone 1 and zone 2. And your trajectory gets retrograde projection on the pars, and wherever it falls on the C2, it can have, and that is the entry point. And this is something that I always emphasize, that entry point, do not go by that 2 millimeter rule that Masashi Neo et al. Had publicized, that 2 millimeter lateral to the medial side of the C2-3 joint. I think that is not something that I follow in my practice. It may be good in their hands or somebody else's hand, but what I recommend is that fix on a lateral image your exit point and just go through the midpoint of the pars and get a retrograde trajectory. I'm also going to be highlighting this in the live surgery that I'm going to show you a video recording of the surgery. But this is something that exit point is fixed, have a retrograde trajectory, and wherever it falls on C2 becomes your entry point. And this is something that I have always been following. And this gives you a 100% prevention of vertebral artery rupture that can happen to you if you do not follow this rule. Sometimes your entry point, if you follow the rule, you may actually be going medial, giving a dural leak, or you may going inferior, resulting into vertebral artery encroachment. So this is something that I always recommend, and this is something that you always must do pre-operatively, and get a 100% result that if your screw tip is lying in zone 1 and zone 2, you will never be able to perforate the vertebral artery which is lying in the lower half. And if your screw is in zone 3 and zone 4, you have 50% chance that you have already perforated the vertebral artery, even though you may not have met bleeding intraoperatively. So zone 1 and zone 2 is something. Again, avoid zone 0, because the moment you have gone into zone 0, you have actually perforated the OC joint here. And these zones are purely based on division of the anterior tubercle of the C1 vertebral body. So this anterior tubercle of the anterior arch of C1 is something that is divided into 3 halves, giving zone 1, 2, 3, and 4. Maximum your screw tip should lie in zone 1 and zone 2, and never in zone 3, 4, and ideally avoid zone 0. This is something that you must pay attention to and get a retrograde trajectory while you exposure. Again, the need for having a true lateral imaging intraoperatively cannot be overemphasized, because your zoning of the anterior tubercle will become absolutely absurd if you do not have a true lateral of the C1 thing, and your screws may be lying good in lateral, but in AP view, they may actually be perforating or missing the C1 lateral mass either laterally or medially. So this is something that we may pay attention to, and this finishes your pre-operative planning. Coming to the basic part of draping. Now, draping has always got to be done all the way down to T3, T4. In fact, right from the occiput to T3, T4. No matter how good a surgeon I am, I may still miss out on having a good trajectory, and I may have to convert my surgery into OC fusion sometimes, and I should be ready. And the occiput should always be kept open for draping, and down all the way to T3, T4, because the transarticular screw is a percutaneous screw nowadays, and the entry point for the guide wire comes all the way from the T1 spinous process, and that is why your exposure or the draping part should be away from, in fact, T3, T4, sometimes to the mid of the scapula all the way up to T5. And this is something that is extremely important. Otherwise, you may actually miss upon the good trajectory and may lead into an unsterile zone. So this is something very important. Your draping should be all the way up to the mid of the scapula, up to T5 should be exposed and covered with a preoperative thing. Keep all the implants ready. Sometimes whenever I do a transarticular screw, I make it a point that I have the smallest cannulated screw in my hand. I have a partially threaded, a completely threaded. And in fact, in kids, I have been doing a lot of transarticular screws, and I keep a Herbert screw ready in my hand, because if my patch diameter is less than 3 millimeter, or it is approximating 2.7 millimeter, there is no cannulated screw that is available less than 3.2 millimeters, whereas Herbert screw is available in 2.6, 2.9, 3.2, 3.5 millimeter diameters. And that is why now it's a standard armamentarium to have a Herbert screw available on table, have cannulated drill bits, have cannulated guide wire, have cannulated screw inserters, and everything percutaneous should be available. And remember, no matter how good a surgeon you are, the chances of you meeting venous bleeding in the C1, C2 area is always there. So keep hemostatic agents like flow seal and gel foam always ready on the table, though it may not be opened up to begin with, but keep ready so that at the knack of time, you can just get these hemostatic agents ready with yourself. And good bipolar tip cautery is extremely important, because this is something that is extremely important to dissect the area where your screw is going to be going there. And the surgical steps can easily be divided into incision, exposure, and insertion of guide wire, followed by screw insertion. Now, when coming to surgical, when you have planned the whole thing in the surgery, 90% of surgery is all about exposure in the C1 and C2 area, because that is the only thing that actually haunts most of us. At least to me, when I began my C1, C2 surgeries, the biggest haunt to me was, will I meet bleeding in the C1, C2 area? Will I have venous bleeding there from the C2 ganglion? Or will I actually be able to prevent myself from having a vascular disaster or vertebral artery injury? And this is something I think 90% of surgery should be purely concentrated on the soft tissue exposure between C1 and C2 in the ganglionic area. So let's just go to the surgery directly. As I just show this is the pre-operative planning of the screw. The screw trajectory is this, and that gives me my entry point, which goes to the most medial aspect of the parts.
The dorsal surface of the parts is laterally on the parts, come out just where even and come out in the center of the.
So this is something that we may pay attention to. And remember, the anterior tubercle of the C1 lies anterior to the lateral mass anterior portion. That's why your screw tip should not cross the anterior shadow of the anterior tubercle. It should actually fall just short in zone 1 and zone 2. The incision is midline, based, centered on C2 spinous process. And that's the C2 spinous process. I've reduced my size of incision to almost 2.5 centimeters. And my average incision size is less than 3 centimeters for all transarticular screws, making it absolutely minimal invasive. The incision is centered on the C2. I always, the 90% of exposure is only about C2 spinous process and C2 lamina. We do not want to see C3. You do not want to see C1 at all. It is only on C2 spinous process, and follow the midline, the posterior yellow line, and go directly to the bone of C2. It's a very prominent spinous process of C2. You just expose the C2 spinous process and follow the C2 spinous process down with the help of your bovine cautery. The cautery strength is kept to the bare minimum, so that the spread of current doesn't lead to any injury to the C1, C2 membrane. And through the lamina, you just dissect all the way up to the lateral aspect of the lamina. Remember, you have to preserve the upper portion of the C1 arch where occiput gets attached to the C1 through a ligament. Do not disturb that. Do not expose it. And similarly, do not disturb the C2-3 joint. Adjacent segment degeneration of C2-3 joint resulting into neck pain is extremely common. And do not disturb the C2-3 joint capsule. That's the lamina of the C2. That's the head end. That's the foot end, the right side and the left side, as you can see on the screen. This is the area where your lamina ends and your pars of the C2 starts. That's where your bovine cautery should stop. And you expose only the C2 without disturbing the C2-3 capsule. The total blood loss in these surgeries is less than 50 ml, or it can be 5 liters. And that is why being absolutely meticulous in your exposure is extremely important. So you can actually see that you have exposed the C2 spinous process, and that's the lamina on the right side, lamina on the left side, and just the initial inferior aspect of posterior tubercle of C1 posterior arch. Now, the most tricky aspect, dissecting the C1, C2 area, which is the venous plexus area. Again, it is very superficial. The depth of your cautery never goes below the bony edge of the C1, C2. So you can actually feel the C1 posterior arch. Only the inferior aspect has to be exposed, because if you expose the superior aspect, inadvertent OC fusion may happen because your graft is going to be lying there. And that is why the connection between the occiput and C1 superior aspect of the posterior arch should not be disturbed, should not be exposed. And you go very gradually, continue dissecting between the C1 and C2, superficially take off the muscles from there, continue with your cautery, avoid going deeper. And the moment you see this blue hue, you know that you have seen the venous plexus. Your bovine cautery should stop here, because the spread of bovine cautery current can actually rupture the venous plexus, and you should just stop here. Now is the time when you would want to use your bipolar and dissect from lamina into the pars and into the C1, C2 joint. So this is the time we have already dissected between the C1 and C2 area. And still we have not seen the C2 pars, because that it is the C2 pars visualization that is very, very important. And your exposure finishes the moment you've seen the whole of C2 pars entering bang into the joint. And seeing the joint is extremely important, not only to get a reduction in irreducible cases where you can put in your puka and distract it, but also to pack in your graft there. And actually, the moment you see your whole C2 pars right in front of you, you will require less number of C-arm shoots. You will have less problems getting your guide wire in, and you can actually visualize that your guide wire is not perforating there. You can actually pack in your graft there. Again, you can see the blue hue here. The whole musculature between the C1 and C2 is dissected, and now what you see is the venous plexus. This blue thing that you can see, a blue hue, is the venous plexus. Believe me, there is not a single time you will rupture it if you are so slow and meticulous using your bovine and bipolar cautery. The moment you see this bluish tinge, you know that you are near the venous plexus of C2 ganglion. You stop there and start bringing your bipolar cautery. So that's the C1 posterior arch. This is the C2 spinous process, the C2 lamina. And now starts the capsule of C3, and your bipolar comes in to walk on the bony aspect of dorsal surface of the C2 pars. And with the help of your bipolar, you gradually just walk on the C2 pars, entering into the C1, C2 joint. You can actually, with your McDonald, use soft tissue patties and enter into the C1, C2 joint. I generally like to use a soft dissection with the help of patty and McDonald, and gradually walk on the C2 pars all the way inside the joint. And if required, just put in my puka there after a dissection of the C2 pars is seen. And mind you, you can see the whole of pars. The whole length of the pars is hardly 15 millimeters. And you can see the whole of 15 millimeters of that pars right in front of you. So dissection carries on, because unless you dissect the soft tissue there, it will be a hindrance. And so dissection above the C2 venous plexus and under the C2 venous plexus, walking on the pars there. Use of bovine is extremely important. Use of bipolar is extremely important because the bovine cautery spreads current and it can lead to a vertebral artery rupture there. It may have a small protrusion there. So this one patty not only goes into the joint, the other patty I would actually pack and push the vertebral artery laterally. So you see this patty is packed lateral to the right side. It is just pushing the vertebral artery in the foramen here. That's the foramen transversorium where the vertebral artery usually lies. You can actually see the whole of, you see, that's the whole of pars seen there. And in this case, the pars diameter was barely 3 millimeters. It was very thin pars on the right side. In the left side, it is 3.7 millimeters. On the right side, it is 3 millimeters. You can see the whole of pars right in front of you. And this gives you a retrograde trajectory there. The whole of pars right in front of you, one patty packed in the foramen to push the vertebral artery laterally. That's the right side. And from there, the retrograde projection actually can tell you that your entry point is now made. And as I always emphasize, that entry point is tailor-made. It is never fixed. Do not go by the joint or 2 millimeter, 3 millimeter dimensions. It is extremely difficult to actually measure 2-3 millimeters, but this is absolutely accurate that your pars, wherever it falls on the lamina, becomes your entry point. And my angle is 5 to 10 degrees laterally outward, because the C2 lateral mass is placed lateral to the C1 lateral mass is placed lateral to the C2 articulated surface. And that is why I start more medially, go to the dorsal surface and the most medial surface of C2. And that's the joint of C2 seen there. My guide wire exits here and goes into the C1. You can actually see the whole length of C2 pars, the patty up there, one patty pushing the vertebral artery laterally. And this is the left side. The moment you have seen this, your surgery is actually over. Now it is a simple surgery. Even with only 5 or 6 lateral C-arm shoots, you can actually get your guide wire in the most dorsal and in the most medial position. And you have actually visualized the trajectory on both the sides. Now your incision and exposure is completed. You do not have to do anything else. Your exposure part is totally over. And while your exposure is complete, you have to ensure that the hemostasis in the pars area is complete. You have to get all the gel foam and other things ready, kept ready in your hand. This is just getting further dissection into that area. Just a repeat of the steps there to see the whole of pars right from the joint, walking on the pars, falling on the lamina on both the sides. This is something that you may always want to doubly check that you have been able to see the whole of pars in front of you. Now comes the most important part, is trajectory planning. As I mentioned, retrograde trajectory falling, wherever it falls on lamina becomes your entry point. And that's where you burr and decorticate the surface in the same lines. And this is again checked on the C-arm view. All these steps of burring happens on the C-arm view. And then you get your cannulated sleeve. This cannulated sleeve comes, like I mentioned, at T1 level or T2 level with a stab incision. This is what makes it absolutely minimal invasive. You are not disturbed the C2-3 joint. You are not exposed it 2.5 centimeter incision, absolutely minimal blood loss. Your guide wire cannulated comes there, sits on the entry point, and under the C-arm guidance, your guide wire goes in on both the sides. And you can actually visualize right in front of you, not only the dorsal aspect of pars, but also you can see the guide wire passing the C2-3 joint. Once your guide wire has gone in, your hand drill, again cannulated drill comes handy. All these steps happen under a C-arm guidance. Remember, the moment your C2 has passed by, there can happen a distraction of the C1, C2 joint while you are using a drill. And this is something that you have to keep in attention, that the distraction of C1, C2 joint should not happen while you're drilling. And once your guide wire is there, gradually your drilling and your screw comes in place. All right in front of your eyes. At all times, the C2 passes right in front of your eyes. And again, the screw passes transarticular in a percutaneous manner, and the screw is driven home. Once this is done, everything of this is absolutely under C-arm control. And you can note the beauty of angulating the sleeve, getting all the way into zone 1 and zone 2 as the endpoint. And grafting. So I always use allograft. We have the facility at Bombay Hospital of using allograft. Now at Leelavati Hospital also we are setting up things around. However, for now we have been using allograft from the TKR and THR colleagues that they provide. Burr the inferior surface of posterior surface and the superior surface of C2 lamina and put the graft in there. Chip in between the C1, C2 joint also. Curate whatever is seen and just pack it with the graft. I never have used a supplemental wiring as it was classically described in Mashashi Magrel's technique. But as I have never been using a supplemental wiring and I have never regretted the idea because almost always we get the fusion. Just a recap of things around. Exposure in C1, C2 area. Dissection with bovine, look at the pars, enter into the joint. Retrograde trajectory, get your guide wire in percutaneously, all under C-arm guidance. Drilling, your screws come in under C-arm guidance. And grafting. And surgery is over. So, as I mentioned, some of my case scenarios in non-union odontoid, you can see established non-union and os odontoidium, transarticular screw, anterior is not the way. A chip fracture of lateral mass C1 with a transverse ligament injury with a avulsion of C1 lateral mass, again transarticular screw, fixing the C1, C2 instability. Patient with hypoplastic atlas with subtle transverse ligament injury, again transarticular screw is the only way to fix, or you can actually do a C1, C2 fixation. However, in such cases, I always prefer a C1, C2 dislocation. Atypical odontoid fractures where anterior osteosynthesis is not recommended, like reverse oblique fractures, smaller fragment comminuted fractures, again transarticular screw comes very handy in such patients. C1, C2 tuberculosis, the joints may be destroyed on one side. However, even a single screw is far more stronger. In such cases, do not go and do a occipital-cervical fixation. Even if one lateral mass is good enough, you can actually add a wiring and do one transarticular screw. Your C1, C2 segmental fixations may not be the best fixation modalities in such patients due to osteoporosis and joint being damaged on one side. So this is something that transarticular screw comes very handy. I have had a big series of C1, C2 tuberculosis. Degenerative C1, C2 osteoarthritis, again, such patients have a very severe occipitalgia and severe restriction of rotation. You do not have to do a OC fusion in them. Actually doing only a transarticular screw really helps. You can actually note the type of fusion that we have achieved in such patients. In patients with inflammatory arthropathy, patients with rheumatoid arthritis, and in kids with JRA, again, this comes very handy. The moment you do anything to expose the upper aspect of C1, they will develop inadvertent OC fusion, and that is why limiting your exposure and minimizing the damage to soft tissue is extremely important to have limited fusion of C1, C2 area only. Not only in normal anatomy, but I was mentioning, even in dysplastic patients, where even in kids with less than 3 millimeter pars, we have tried this. And the challenges in these cases are extremely high. However, though in initial days, you may not want to try this, but as you grow up, we have did a big series of pediatrics C1, C2 dislocations. And as I mentioned that the pars in kids also attain adult size by the time they are 8 years of age. And so 8 years and above, it is as like any adult C1, C2 dislocation treated by transarticular screw. And the importance of pre-operative planning cannot be overemphasized more than in the pediatric population. One kid who presented only with torticollis and nothing else had a rotatory C1, C2 dislocation. We used a Herbert screw in such patients. Again, zone 1, zone 2 stabilization. Wonderful fusion achieved. Odontoid malunion. This kid had a maltreated odontoid fracture only in a cervical collar. Again, presenting with torticollis, looking like a irreducible one. But as you see, a pull-push technique, the push on the C1 from front and push on the C2 from back results into good reduction, and you can actually achieve a malunion getting into a reducible C1, C2 dislocation. Even a high riding vertebral artery, as I mentioned, it's very ambiguous because there is no obvious definition of high riding vertebral artery till day. And navigation here, we have been using it for last 6 years now, has given us wings to fly. Even in patients with 2.7 millimeter parts, we can actually get in a precise trajectory of transarticular screw, saving us from doing any occipital fusion in such patients, or going down to C3 may not actually be required. One such case example with Marfan syndrome, only 2.7 millimeter of parts there. We did a transarticular screw fixation using navigation in such patients. And navigation not only adds precision, but also has reduced the amount of radiation that is required in such patients. Another case of navigation guided minimal invasive odontoid in young patient. Neurogenic tumors with eroded joints, again, we have did transarticular screws. And as I just mentioned, that occipital-cervical kyphoscoliosis, which otherwise would require a long segment subaxial fixation, we have now recently just got this paper published where occiput to C2 is the best construct. You really actually do not have to go to C3, C4, or C5. Your construct of occipital-cervical fusion can only stop at C2, provided your C2 has become a solid strut construct by making it into a transarticular screw, because it is the strongest hold in the cervical spine. So O to C2 fixation, where the C2 becomes a transarticular, is something that I have recommended, not only in...
Thanks, Vishal. We'll sum up.
Yes, fusion rates are 100% in such patients. And of course, there are problems which we'll probably not go into at this point. Thank you so much, Satya.
Thank you, Vishal. Nice presentation, very detailed presentation on C1, C2 stabilizations. Arjun, if there are any questions, you can take it.
I think we'll get to the next talk and then have the questions together, because we are a little bit,
Arjun, can I just make a small comment, because I will be not there
Okay.
later on. So excellent talk and excellent exposition of the technique. A few little things is that to avoid things like distraction and slipping, I normally put both the guide wires. So I will put a guide wire on the one side and the guide wire on the other side, and then put the screw. So I won't do just one side first. So this is slightly better to prevent it from distracting. And in those which are completely unstable, there is still a role of doing a wiring, because the wiring also helps put the edge graft in place. So what you would then do when it's a very unstable thing. So you get a reduction, you do the proper galley fusion with the wiring and the bone graft, and then you put the screws. So this makes sure that it doesn't slip, it doesn't it doesn't sort of get out. Because even classically with the galley fusion, which is a 3-point fixation, the fusion rate is 96%. So that means a few cases are not getting fused. So I'm not saying you should wire every case, but you should also not say that we don't need to wire at all. There are some cases where wiring helps. But a good intra-articular fusion is also important, to put your curved curette inside and remove the cartilage and pack some bone graft through the pars into the joint also works very well. But all in all, an excellent exposition. And these jigs with the cannulated jigs have really helped to decrease our main incisions. So previously when we were with Dr. Lahiri, we used to do KIs and drills and put it directly, and we used to have big incisions, and of course that's what started the technique, but now there is better instrumentation for it. But great talk, Vishal.
With the transarticulars, sometimes you can have kyphosis later, because in your experience, what's your take on that?
I think the kyphosis happens at C2-3 joint only, and that happens only when you have disturbed the C2-3 joint capsule, or you have taken down a lot of musculature from the C2. If you see here, not only that the exposure is limited only to C2. So that's the very important aspect, that please do not distract, disturb, or burn the C2-3 joint, and you will not develop a proximal or distal junctional kyphosis after a C1-C2 fusion. And in my experience, we have not had a single case where swan neck deformity, what you classically mentioned, that C1-C2 is fused, but it starts toppling at a C2-3 joint. So it doesn't happen if you preserve the C2-3 capsule and do not take the muscle or interspinous ligament between the C2-3 joint.
So I'd like to, I'm sort of not as optimistic about doing transarticular in all cases as Vishal is. And I'd like to have, the opinion of Dr. Dalvi and Dr. Nene on this. So how many percentage of patients you'll do transarticular? How many patients are you doing, percentage are you doing OC fusion or C1, C2 fusions, sort of.
So my procedure of choice is the transarticular. Like if I can get a transarticular, there is nothing like it, because it is really it's minimally invasive. There is no mess. You don't have to fiddle with the plexus, and the screw, and it's biomechanically rock solid because you're just transfixing the screw. But if there is any issue, so there can be some issues. The first issue is getting a trajectory. Like if you can't get a trajectory because of this very thick sort of shoulders, or what I mean, you can't get the neck in position, and the hump comes in the way. There is a dorsal kyphosis. upper dorsal kyphosis. Or sometimes you hit it and then there's some major bleeding and you are terrified. Then you may switch to the C1, C2 separate screws. But given a choice, my first choice is always transarticular. First choice. There is no arguing about that.
Dr. Nene,
Yeah.
any thoughts? Okay, so while we're waiting for him to get back, I think we'll go ahead with the next talk, I think.
So the next talk is by Dr. Arjun Dhavale. Please start the video.
Hello, everybody. I'm going to be speaking about avoiding vertebral artery injury in CBJ surgeries. I'd like to thank the organizers for this opportunity. So basically, there are 4 A's: the anatomy, the assessment, the avoidance, and the action when it comes to vertebral artery injuries. And I'm going to be touching on all these 4 aspects. So starting with the anatomy, it's very important to understand this before doing these surgeries. So the vertebral artery basically has been divided into 4 segments: the V1, the V2, the V3, and the V4. And the area of interest with the CBJ is the V3 and the V4 segments. Now it's important to understand the anatomy of the subaxial spine and the position of the transverse foramen, which is more anterior, and it moves to a more posterior position in a cephalad direction. It's also important to understand that there can be aberrant subaxial vertebral arteries, for example, as seen here. And if one is instrumenting the subaxial spine, it's important to appreciate this on the CT scan. Now, when it comes to the C1, it's important that the instrumentation is done from the lateral mass and not from the arch, because there is a 5.4% variation in this segment, and it is possible to injure the vertebral artery if the entry point is not correctly determined. It's also important to remove the overhang of the C1 arch before the screw placement. And the C1 lateral mass screw is basically angled 15 degrees medially to avoid the vertebral artery, which is more lateral. Now, this is a an atypical study by Cacchiola and Goel, where they basically looked at cadaveric specimens and what the terminology commonly used for the V1, V2, and V3. And the V1 is from the C3 transverse foramen to the C2 transverse foramen. The V2 is from the C2 transverse foramen to the C1 transverse foramen. And the V3 is from the transverse foramen of C1 to the dural entry. Now, it's very important to understand that there can be an aberrant path, which is depicted here, with this intersegmental artery, which is going below the C1 arch, and a fenestrated vertebral artery where there are 2 components, one beneath and one above. And if one misses this, there can be a problem. Now, it's also important to understand the foramen arcuale, which is basically when there is a bony arch overhanging the vertebral artery. And as can be seen here, if that overhang, and that arch is sort of missed, and you make an entry point from the arcuale, then basically you can injure the vertebral artery. We're coming to C2. The C2 vertebral artery anatomy is very important to identify that high riding vertebral artery based on the isthmus height and the internal C2 height. And a C2 pedicle screw usually is placed only if it's not a high riding or a very medial vertebral artery. And usually the starting point is superior and medial to the center of the lateral mass and aimed 10 degrees medially and 15 degrees cephalad. And the very interesting finding is that in 23% of patients, the C2 isthmus is too small to accommodate a unilateral 3.5 transarticular screw. So it's very important that we preoperatively plan. In 6% patients, it may not accommodate a screw on both sides. So understanding the concept of the internal height, the isthmus height and the medial displacement on the reformatted CT scan images is critical because it helps for the preoperative planning. This is an example of that. And actually, Kalyan Tadepalli, our DNB resident, had come up with this classification, which is looking at the internal height, the isthmus height, and the medial displacement. And he subdivided them into these categories. And actually, the LAO is the one where it's easy to instrument, with a pedicle screw or a transarticular screw, while the HPI here basically is the one which is difficult to instrument, and you need to look for alternative modalities of fixation. So coming to the assessment and avoidance, this is the most important aspect, and I would recommend that you all read this article by Kshitij, and me, and looking at the planning basically for the three-dimensional and multiplanar reformatted CT, in craniovertebral anomalies. So basically, the tier 1 data, which we usually look at, are the CT scan films. The tier 2 data is basically the PACS images, and the tier 3 data is the multiplanar reconstruction, which we do, where we can take non-orthogonal sections, and that's actually the subject of the paper. Now on this, you can actually plan your trajectories. You can plan the implant sizes and your entry points. You can plan everything. Now the volume rendering software basically helps you to understand the anatomy, real time before the surgery. So basically, the CT scan DICOM images of 1 millimeter thickness are manipulated for volume rendering and for the multiplanar reconstruction. And this can be used for determining the pathoanatomy and the fixation anchors. So, for example, this is a 10-year-old girl, who had a basal invagination with a C2 lysis. And when you look at the volume rendered image, you can see that the vertebral artery is lying in that C2 lysis area. And to avoid injury here, basically, fixation had to be done with a claw construct with hooks distally. There's another example of a child with skeletal dysplasia with atlantoaxial instability. And as you can see here, the os is noted, but the plain CT does not help us as much as the MPR images, and you can make out that there is a medial and superior vertebral artery here, which is high riding. And so in this case, one has to use a alternative to a pedicle screw on one side. And here a pedicle screw on one side and a laminar screw was used on the other side. So it's important to understand that the exposure of the C1 has to be done carefully. The lateral dissection should be limited to 15 millimeters. And ideally, the dissection should be along the inferior aspect because that's safer as the vertebral artery runs along the superior edge. It's also important to maintain meticulous hemostasis as there can be significant bleeding from the plexus, and this is best controlled with thrombin soaked gel. This is another example of a 2-year-old child, very dysplastic spine. And here basically it was not possible to use any screws, so Marcelline tape was used along the arches for fixation. So what do you do if you actually have a vertebral artery injury? It's a problem. You have to achieve control of the hemorrhage, prevent CNS ischemia, prevent post-op complications like embolism and pseudoaneurysm. It's important to control the bleeding. This can be done by primary repair, bypass surgery, or ligation. Intravenous access for fluid resuscitation. The head should be neutral so that the opposite vertebral artery is not kinked. Digital pressure, followed by large hemostatic agents. Because small agents might, small pieces may cause embolism. The VA must be well visualized for proximal and distal control. That may, require you to dissect around the foramen transfer surgeon using a temporary aneurysm clip or a vessel loop and a direct repair. Endovascular repair has also been described. So this is an example of a child we treated, who actually presented with vertebral artery injury resulting in a posterior circulation stroke, sagittal dysplasia. And here actually the diagnosis was made on flexion extension X-rays. He had an os, and preoperative planning was done, and the transarticular screw was not attempted as this was a case of bilateral VA thrombosis. And an OC2 fusion was planned with the pedicle screw on one side and laminar screw on the other side. So to end, I'll say that it's important to assess the 4 A's: the anatomy, assessment, avoidance, and action for a safe surgery. Thank you very much.
Thank you, Dr. Arjun, for this lovely talk. So if there are any questions, we can take them now for Dr. Arjun and Dr. Vishal both.
So Arjun, about the vertebral artery injuries, supposing you do actually injure a vertebral artery during your surgery, what can you do for this to stop the bleeding, etc.? And after that, what is the post-operative protocol then?
So, I've had one. So it's a good idea to start with the non-dominant. You start the instrumentation on the non-dominant side, because whatever the outcome will be, it'll be less if it's a non-dominant vertebral artery injury versus a dominant vertebral artery injury. Okay? So when you are deciding on your instrumentation, which side you should start with, you're better off going with the non-dominant side. If you have a problem on that side, then you can just change what you're going to do. Then for sure you can't do a transarticular on the other side. Okay, then you have to sort of go ahead and just the safest thing then would be to go to the occiput and go to C2 and maybe use cables, etc. Okay, because you can't, or use a laminar screw wherein your risk of a injury is less. The pre-op CT angio, I think, is the critical aspect here. So I always start on the non-dominant side. I'll never start on the non-dominant side. Unfortunately, the one where I had the injury was on non-dominant, so the implication was not so much. If you have a dominant vertebral artery injury, then there can be significant issues, and of course you need to then first stop the bleeding, because if you don't stop the bleeding, you'll have a mortality, and you can instantly recognize the way fortunately it was possible to stop it in that patient where I had, and it's just pressure first, pressure using bone wax, etc., and then trying to assess what's to be done. See that you have some instrumentation in, so that at least you pack it, and then you can kind of do the contralateral side, so that at least you can bail out, because you can't leave the spine unstable, so you can't abandon, but at least having unilateral fixation then will help, and then of course involving the team, so if you have access to an endovascular surgeon, yes. If you have access to a vascular surgeon, yes. Ligating it is not ideal, if you can, you should try to get it repaired with help, but yeah, it's a problem you don't want to face, and actually that's the reason. So the reason I've sort of spoken about it, with this balance is I actually believe that many of those cases it was not possible to do a transarticular. All right, so and if you try to attempt it, you will sort of land up in a soup if you can't recognize that situation, and there is bleeding from the plexus. It's actually case variable. There will be some cases where you won't have bleeding, and there will be some cases where you will have bleeding from the plexus. I think it's, of course, surgical experience and also the anatomy, and what sort of cases you get. And of course, Vishal has done a lot of cases, but
Vishal,
it's always a new case. Actually, it's always a new case, and you don't know what you're going to encounter. I feel, it's always that the unknown. So
yeah. So once we have controlled this, Vishal, after the patient is out of anesthesia, is there anything specific that you would be doing? Of course, checking neurology, but after that.
Once you've had a vertebral artery injury, there is a complete set of or a protocol that has to be followed. One is, of course, intraoperatively after the patient is turned down, you have controlled the bleeding. The first and foremost thing is to ensure whether there has been a completely ruptured thing or it is just a partial thing, number one. And then sequential interval imaging is extremely important. Also, a vascular interventional radiologist should also see if there is a possibility of stenting it, because if stenting is possible, it can be done only in acute phase to prevent any pseudoaneurysm. Because a pseudoaneurysm formation in vertebral artery at that location can not only be a cause of progressive neurology at a later date, but also it can lead to a sudden death or a ataxia at a later date due to aneurysm ruptures, aneurysm embolisms, and aneurysm thromboembolisms. So aneurysm prevention is extremely important, and that can only be done in acute phase. An initial CT scan angiography followed by an interval at 48 hours is extremely important, with a reference to interventional radiologist to see the possibility of doing this. If it has not happened in 48 hours, I think the chances of aneurysm development at a later date still is there, but is very low. And the first time you see it with a sequential MRI at a yearly interval, you should just coil it at a later date then.
I think you have to have, alternative fixation options available. Like that's the key. So sublaminar wires, you should have Marcelline tape, the cables, you should have all the things available, because if you can't go ahead with one possibility, I mean, if you're planning transarticular, you should still have OC instrumentation available. I mean, that's important.
Extremely important, because the surgery has to go on despite a vertebral artery injury, because if you have had a vertebral artery injury, the moment you are able to salvage the bleeding, you should finish the surgery, because the unstable situation today, whatever you have left there, it has to be stabilized, because tomorrow, even from vertebral artery point of view, you will need a stable cervical spine to not only salvage the injury that you have created. And for that, a stable injury is very, very important, because unstable cervical spine can actually pose danger to the other side vertebral artery also. So even if it means just wiring it, even if it means just posing a lot of graft there, doing an instrumented fusion, but the surgery has to finish and fusion has to be established in that area.
Good. Some good points we've got out here. Over to you, Agni.
Yeah, thank you. So in interest of time, let's move to the next session. So the next session is extended indications for the MIS tube decompression. And I would like to invite Dr. Sudhir Dubey for his talk. Dr. Sudhir Dubey is a senior consultant neurosurgeon at Medanta Hospital, Gurgaon. So can we have his talk, please?
Good day, friends. I'm going to share my experience on minimally invasive surgery for thoracic spine. Thoracic spine is one of the challenging areas of the spinal canal, where you have a rib cage and the great vessels with heart and pleura in front, the ribs on the side and scapula still on the sides on the back. This forms unique set of challenges to approach the spinal canal and spinal pathology. Even vertebral body approaches and the disc approaches in these areas are fraught with challenges and dangers. The thoracic spinal cord is a very unforgiving area for trauma, because the blood supply is very precarious and the spinal canal in the thoracic spine is the narrowest. Indication for surgeries in thoracic spine include degenerative, traumatic, neoplastic, infective, and idiopathic. Principles remain: decompression of canal to maintain a good alignment in the coronal and sagittal plane, to preserve motion, and in case of instability to fix and prevent abnormal movements. Over the decades, various surgeries have been practiced for the thoracic spine, which include open, mini-open, video-assisted thoracoscopic, minimally invasive. We all stand on the shoulder of giants. The previous generation leads the foundation for the new generation to achieve more brighter things. These are the various surgeries used to be performed in 1990s and 2000, and they included transthoracic approaches, mini transthoracic approaches, lateral extrapleural approaches, non-muscle splitting, and lateral extracavitatory approaches. Now, for the past 15 or so years, we have gone on to the tubes. Approaches depends on where you are approaching the spinal canal, where the pathology is lying, can be in the form of hemiaminectomy. If you go slightly more, remove facet and pedicular, that is transforaminal. Then you go lateral to the foramen, that is extraforaminal, and then tailored extraforaminal, in which you can do a little bit of transforaminal and extraforaminal approach. Then when your approach becomes more ventral, then you have to push the pleura in front without damaging it. Then it becomes a transthoracic retropleural approach, and various approaches like thoracoscopic approaches, tailored multisegmental decompression, fixation, and deformity correction. This is for trauma and deformity. And open trapdoor manupriotomy. This is for the upper thoracic spine from D1 to D3 areas. The corridors for the first approach is a tailored hemilaminectomy, in which we dock our ports onto the junction between the spinous process, lamina, and the articular facet. This is ideal for the pathology in the spinal canal, which is in the spinal cord, has been put or pushed on the sides. This is one illustrative case where you have a ossification of ligamentum flavum and a small disc, thoracic disc, and there is severe significant canal compromise. In this approach, you will go with a dock with a port, and you will drill this thing off and achieve good results. Similar case of a tumor, in which there is a tumor of the thoracic canal in the intramedullary infradural tumor, extramedullary infradural tumor. So first you will make a hemilaminectomy, go across the midline, give adequate space. You have around 130 degrees of exposure. You will open the dura, expose the tumor, because most of the neurofibromas are present dorsolaterally. So your spinal cord is on the opposite side, behind the lamina on the opposite side. So you will just open, decompress, follow the principles of dissection, decompression, and tumor mobilization. This is CUSA, in which you are reducing the amount of tumor which is present. At all moments of time, you should have a visual idea where exactly your spinal cord is there. The final portion of the tumor, in which you dissect it out from the final nerve root. In thoracic spine, you have to sacrifice the nerve root, and there won't be any deficit grossly, even if it's a motor root. Generally, it's a sensory root. Closure of dura is an important process, interrupted stitches so that there is no leak, and you can achieve good results. And the most important thing, the cord was always on that side and you never really injured it. The second approach is tailored transforaminal, where you will take out part of the facets and the pedicle. In this, your docking is more lateral to the previous one, where you were more on the spinous process and lamina. Here you are more on the facet and the lamina. And this is for pathologies which are located into the foraminal area. And this forms an approach. This is a case of a hemangioma which has come out, caused a collapse. And when you go, we have put a bone cement inside to augment the vertebral body. And now, because it was going into the both foraminal spaces, the hemangioma, what we are doing is we are decompressing the spinal canal so that there is no recurrence there. So gradually, because there's a lot of blood loss in a hemangioma, once you have put the bone cement, the blood loss becomes less. And if you are fast, you will have more controls. And as the hemangioma gets excised, the blood loss becomes minimal. And because the hemangioma is a bilateral phenomena, we will also go on the opposite side as shown. Be fast, take out all the bones, and in some cases, we also leave a screw there. The third approach cortical, is an extraforaminal approach. Compared to a transforaminal, this also looks like this, but in this, you are going from the sides into the foramen. You are not doing any great bony work. You can do some drilling from the lateral side. So this is in cases of tumors and in cases of thoracic disc. So this is a cystic tumor present in the foramen and going into the inside the rib cage. And this is what the video shows like. Once you dock, this is a pleura. You can see it pulsating. You have to go on dissecting it bit by bit. It's a cystic one, as you saw on that scan. So you are seeing the cyst. And you have to know which level it is. If it's a D2 level, it's not going to be important. And gradually, once you have defined the cyst, you are going to take this tumor out. So this is the final part where you have dissected it off. This is the final part of the tumor which you have turned to one side. And this you will pluck it out. In cases of thoracic discs, you will land into an area which is lateral to the facet. This is the facet joint. This is the lateral space. And this is the disc which we are seeing from the lateral part. So this we have because the thoracic spine, the pedicles are more medial. We are able to see this disc space if we have a small port and we go at the right place. A small amount of lateral bony work doesn't cause any instability. This is the disc which is getting incised. And once you have incised the disc, you start seeing part of the dura and you see more of disc. And gradually you take out the disc and you can really decompress it quite well, see the pulsations of the thoracic dura. The fourth is tailored extraforaminal approach, where you will use extraforaminal approach and do part of bone work as much as necessary. You may remove a part of rib or part of the facet. Now this is for problems which are ventral in the spinal canal in the center, or these are for problems which are inside the body which are there. So this is an illustrative video. This is a case of a thoracic disc which had gone into the center part. So you can see we are going in front, and this is an endoscope, cranial endoscope, 30 degrees, and we are taking out the last remnants of disc which are pressing the cord. So we are very sure what we are able to achieve with this methodology. And this is the final portion of the thing which we are removing from this side. So this is what we have achieved in this case. Now, in this you can put a cage and you can put a posterior fixation also. Then the transthoracic retropleural approach will be for the vertebral body diseases which are going into the spinal canal and causing compression, where you have to achieve adequate decompression. So this will be the approach plane which you use, and you have to reach this level. You will remove this part of compressing element which is going behind, and you can get good results with this. So in this you will remove a part of the rib cage, drilled from the lateral side. We'll remove the facet. And we can show the canal. Similarly, pedicle drilling we are doing in this. The pedicle in this case will lead us to the vertebral body, which we can gradually do, and then do a discectomy above. Because this is a corpectomy procedure, we will do a discectomy above, discectomy below. And then we will dissect the dura of the vertebral bone cortex, this which we have preserved. This is going inside the canal. So gradually we were going to shift it down so that the pressing thing on the vertebral body becomes less. There will be some epidural ooze. So retropulse bone fragment is getting removed. And this will free the spinal canal. You can see the dura which has started bulging here now. And you can achieve a hemostasis. There will be epidural oozes initially, but just putting a gel foam will be fine. And then we put a cage inside so that we can, this is expandable cage. Once you put it inside, you will expand it and you can see good dural decompression. This also is a cage here and we can achieve good results. The surgical pearls for doing a thoracic spine surgery is navigating of the soft tissues. You should plan your entry in the caudomedial and the mediolateral direction, caudocranial and the mediolateral directions. So this is a bilateral procedure. We have a navigation here. You should appreciate the muscles which are present. So whenever you are incising, you try to separate the muscles rather than burning them. But in thoracic spine, especially in this part, you have multiple layers. So some layers will definitely get burned, but when you're stitching it back, make sure that the layers are properly followed. Incision, once it has been planned, you have to dock onto that place and docking becomes important. So once you are there, then you start going, and your port where you are going to place, where is your entry point is most important. And you have a projection thing on navigation where exactly you have to dock on this. Once you have to go there, you have to cause some injury, collateral damage to the bones, because that is your corridor, approach corridor. And you have to disrupt the bones and have to form a window and a safe passage into the vertebral body. And once you are inside, you should know where is your top end, where is your bottom end. This you can know with your C-arms or with navigation. Now, whenever you are doing this procedure, you should always have an idea where exactly is the spinal canal, because that is something which you have to save when you are doing this procedure. And you should always know when you are going in front and where you are in craniocaudal direction. And gradually you have to decompress all these areas. In the end, decompression only is not everything. You have to reconstruct whatever you do. So once you have done that, you confirm it with, you see all the dura which is there, use a cranial endoscope to do it, and then you insert the cage also with it. So these are our experiences. We have complications. We have done 4 levels at long out of more than 200 cases. One tumor migrated in the dorsal spine, and we had to do an intraop MRI and again operate at a lower level. We had dural tears in 9, but they were, because of minimally invasive procedure, they were never problematic. We never had a duropleural fistula, so that is fine. CSF pleural fistula can be sometimes very devastating. Dysesthesia and intercostal nerve supply can happen for a few weeks, especially when people have tuberculosis. Superficial wound infections we had in 8, which was minor, just antibiotics. Hemothorax we had in 2, and we had to put a chest drain and keep it there. Transient weakness in cases of severe cord compression we had, which improved. 2 patients had permanent neurological morbidity. They had already compromised function, but they made minimal improvement or slight deterioration post-surgery. So minimally invasive thoracic surgery is a feasible option for spine pathology. Unilateral approach can provide 200 degree decompression, and it is less morbid than thoracotomy procedures from other procedures which are there. I thank you for your attention, and I'm open for any questions which you have. Most
All right. Thank you, sir, for a great talk. So you're pushing the limits actually. I have a couple of sort of questions. So conventional teaching is that anterior thoracic disc should be approached with an anterior approach, and you kind of go along the pedicle and then remove the pedicle and then get the disc out. So sort of doing it posteriorly or posterolaterally, there is some risk of neurological deficit. So anything you have to sort of comment on how to circumvent those risks?
So as I had shown in this thing, I will all approach everything extraforaminally, not through the pedicle, except in some cases where if I have to go to ventral part, then because I want an access in 200 degrees, so because some retraction of dura is also required, so I will do the facet removal, go extraforaminally and take out the rib also. So that is giving me around 90 degrees of access to this, and that helps me to achieve the results. So it's never through the pedicle only that you will do this disc. You will always go extraforaminally more lateral to what the pedicle line is. You have to always know where your lateral pedicular line is, and you have to be lateral to it.
If it is a calcified disc, is there any difference in the way you'll approach it?
Yeah, then I will make more rib to be cut. So my approach will become more lateral and my angle will be more straight in the line of the calcified disc. Actually, the first case which I did was a calcified disc only, which I did like this. And patient was paraplegic and he improved actually in the post-op. So that was the biggest thing. And this is around 15 years back. So that was the biggest thing which made me do this minimally invasive thoracic surgery. You have to be ventral to the cord. You don't retract the cord. So the more lateral you go towards the
very lovely video,
and the rib, you will be less retracting to that.
The other question I had was, when you're looking at intradural tumors and doing them minimally invasive, so or below, so that you're able to kind of delineate the margins. Now, if you are doing it with a tube, are you limited? Are you limited in terms of your durotomy and your repair and then your
See, there are two kinds of tumors which you will most often do for this. One is a neurofibroma, which if you decompress, you will get that thing. But whenever you are doing an exposure, you will do an exposure above and below that. And for a meningioma, in fact, which is ventrally placed, you have to make sure your docking is at the right place. And once you decompress the maximum bulk of the tumor, the sides will start collapsing. So it's not a problem. But you have to be patient and you have to believe that it is slow internal decompression and capsule dissection which you have to do.
And what about the dural repair? Is it difficult sometimes through the tubes? Or
see, I've done so many and I've caused adequate amount of dural tears. And if you are minimally invasive, you even sometimes I have been unable to control I couldn't put a stitch ventral. Once I had in a corpectomy, ventral to the cord I had. So what I did was I put a duraform and then I put a lot of gel foams above the cage which I had put so that I get a adequate sealing there. And after that, I didn't even have to bother about it. So that was it. That at the operation site, make sure there is no prolapse of the nerve roots. That is one thing, because prolapse nerve root syndrome also it causes sometimes. So first, no prolapse of the nerve roots, and it should be adequately covered, and there should not be any dead space there. So just to do that, it is fine because outside it's quite a distance when you come out. And other thing is sometimes you may have a pleural connection, so avoid that also, because I have read a lot of literature for this and I found that one of the most difficult problems to settle is if there is a CSF pleural fistula. But I didn't had any, so I don't have that experience, but I've read about it in the literature.
Thank you, sir. Excellent talk.
Yeah.
Right. Thank you so much. So we move on to our next talk, which is by Dr. Murali Krishna. Dr. Murali Krishna is a senior consultant neurosurgeon at Fortis Hospital, Bangalore. Can we have the talk, please?
Everyone. My topic is extended indications for tube-assisted MIS decompressions. Minimally invasive spinal procedures and technologies have been developed to achieve the same operative goals as open spinal procedures with less disturbance of normal anatomy. The evolution of techniques and principles have led to significant advances in field over past 3 decades. The various procedures that can be done through MISS are discectomy without fusion, lateral foraminotomy, various types of fusions, fusions with vertebroplasty and kyphoplasty, tumor and cyst excision, cervical decompression, cervical laminoforaminotomy, vertebrectomy, thoracoscopic sympathectomy, tumor and biopsy. Lateral foraminotomy. Foraminal stenosis due to facial arthropathy, osteophytes or disc herniation can cause radiculopathy. Persistent symptoms in spite of conservative therapy, surgery. The available surgical options are hysterectomy with instrumentation or lateral transverse approaches, transforaminal endoscopy, minimally invasive lateral foraminotomy. This patient with persistent lower limb radiculopathy with no axial back pain, MRI shows L4-5 foraminal stenosis on left side. For this patient, we did left-sided L4-5 foraminotomy. Under GA, patient is position prone. A small incision was made 3.5 centimeters lateral to the midline with the help of matrix tissue dilate system and tubular retractor. We reached directly over the junction of facet joint, pars, and the transverse process. The lateral aspect of neural foramen was opened by drilling lateral 2 to 3 millimeters of pars and superolateral aspect of facet joint, and ligamentum flavum was removed and exiting nerve root was seen. You can see the foraminectomy of size 1 centimeter. Postoperative CT scan shows partial facetectomy with preservation of facet joint. So a minimally invasive lateral foraminectomy with partial lateral facetectomy is an effective alternative technique for treatment of radiculopathy due to foraminal stenosis. Minimally invasive posterior cervical foraminectomy. Cervical radiculopathy caused by compression of cervical nerve root due to disc herniation or foraminal stenosis. Surgery is indicated for patients that are refractory to conservative management. Anterior cervical discectomy and fusion and posterior cervical foraminectomy are safe and effective surgical approaches. ACDF has its own advantages and disadvantages. Cervical foraminectomy can avoid ventral approach related complications. It does not require fusion, so no pseudoarthrosis and no instrumentation failure, and decreased incidence of adjacent segment degeneration. We can visualize the compressed nerve root directly and confirm the decompression. It is not indicated for large central disc herniation, and it does not require reconstruction and fusion and may be associated with higher incidence of revision surgery than ACDF. MIS approach can reduce the collateral damage. MRI of cervical spine shows C4-5 lateral disc herniation. With the help of matrix tissue dilator system and tubular retractor, the junction of lamina and facet joint was reached. With high-speed drill, the junction of the lamina and the facet joint was drilled both cranially and caudally, and ligament was removed to see the nerve root. The nerve root was gently elevated and discectomy was done. So foraminotomy is as safe and as effective as ACDF in treatment of cervical radiculopathy. Of lesions. Spinal tuberculosis would be diagnosed in endemic regions such as India on basis of clinical and radiological assessment. Tissue diagnosis was not considered necessary as this was the most common spinal infection. But with emergence of drug-resistant tuberculosis and atypical infections, tissue diagnosis and culture have become mandatory. Percutaneous biopsy can be performed under fluoroscopy and CT scan, but positive rate was around 35 to 90%. Open biopsies have higher rate of success than percutaneous procedures, even if repeated percutaneous biopsies turn out negative. This patient presented with upper back pain. CT and MRI shows lesion involving the D2 left facet pedicle involving the body with adjacent soft tissue enhancement. Matrix tube was used and D2 left side pedicle was reached directly and the bone was drilled and the lesion was taken for biopsy. Histopathology came as tuberculosis. MIS for spine tumor. This 54-year-old male patient who presented with low back pain and with signs and symptoms of myeloradiculopathy. MRI showed D12 intradural extramedullary mass with pushing the conus towards the left side. With matrix dilator system, we did a D12 right-sided hemilaminectomy. Dura was incised and initially tumor decompression was done. Once the tumor decompression was done, we started mobilizing the tumor. And its origin from the nerve root was coagulated and cut and is separated from adjacent nerve roots by sharp dissection, and the lot attachment to one of the nerve roots were disconnected and tumor was excised and the dura was closed with liga clips and reinforced with fibrin glue. Patient was relieved of the symptoms completely. Postoperative MRI showed complete surgical clearance of the lesion. So almost all open spine procedures can be done through MIS. The routes in MIS are based primarily on technique modification, which minimizes the collateral damage, reduce overall stress to the patient, conserve the normal anatomy. Thank you.
Thank you so much, Dr. Murli, for this excellent talk. If there are any questions, we can take them now. Dr. Satyan, Dr. Dheeraj, any comments, any questions? Dr. Arjun?
Can you elaborate on your patient selection?
For what procedure, sir? Yeah.
For the for the tumors especially.
Tumors, we'll be doing all intradural extramedullary tumors with hemilaminectomies with tube only, but not for any intramedullary tumors. Intramedullary tumors, we conventionally do open laminectomy and adequate exposure and do a fixation. But usually we will select intradural extramedullary and extradural lesions, only minimal access.
Dr. Murli, is there a problem with the tube while you're dissecting or when you're mobilizing the tumors, that there is a chance that you may manipulate the neural elements more if you can't see them very well as opposed to doing it open microscopically?
Yeah, especially if the cord is pushed to one side, the tumor is purely lateralized to one side, then it's easy. So if it's more posterolateral or anterolateral, then you have to do extended lateral approaches to remove the tumor. So in that case, we will not use the small tube to remove the tumors.
Thank you, Dr. Murli. I guess, Dr. Agnivesh, we can start the case discussions.
Yeah, I think let's move to the next session, which is the case discussion. It's always interesting to discuss cases, more insight, more discussion. So for the case discussion, I would like to invite the panelists. Dr. Manish Kothari is going to join us in some time. Dr. Vishal Kunnani, who is a senior spine surgeon. Dr. Arjun Davle, my co-moderator of the session. Dr. Sudhir Dubey, sir, senior consultant neurosurgeon from Medanta Medicity. Dr. Murli Krishna, please stay back as panelist. Dr. Gautam Zaveri, sir, senior consultant spine surgeon from Bombay, and Dr. Abhay Nene. And I would also like to invite Dr. Dheeraj as a panelist to pitch in. So if Nene sir is ready, can we start with his case?
Please allow screen sharing for Dr. Nene.
Sir, it's already permitted.
Okay, do we have Nene sir around? Can we reach him?
Yeah, he's there. He'll be joining soon. Meanwhile, while we are waiting for there we go.
Yeah, my computer was hanging. I'm sorry. So I was trying to send messages. There you go. So I just have a very small case because it's 10 minutes per case. And this is a very typical situation.
Sorry, it's 15 minutes, sir. You're spending 15. So
okay, but it's still small. So I'll try to talk about it for 15 minutes. So there's an elderly lady who's a compensated lumbar stenotic with a degenerative spondylolisthesis, who's been walking around with a short distance for a long time, who now comes with a domestic fall and significant instability pain. So this is the kind of picture that she comes with, and it's quite common, I think, nowadays to have older people, tumbling over because of their instability in the legs. And unfortunately, these are only representative MRI images. But as you can see, the lumbar stenosis is pretty tight, and it's surgical in that sense. There's no thoracolumbar conus compression on imaging, but there is a significant collapse of the L1 body. So can I shoot this out to any one of the panelists? Arjun, can you comment if you're a panelist? How would you what are the problems here?
So the problems, basically, we have that L4-5 degenerative spondylolisthesis. We have that osteoporotic fracture proximally, and this is osteoporotic bone basically. So the factors, to sort of look at is that retropulse fragment, the severe stenosis at 4-5 and the osteoporotic bone. So how would you kind of go ahead with this in view of all these aspects?
Gautam, normally, how do you differentiate in your head whether you want to treat the stenosis or only the fracture? Is there a methodology that you use? Gautam, you're muted.
I think what you pointed out, Abhay, is very vital, and that is that the patient had a stable claudication distance for more than 2 years, which was a 100-meter walking distance, and the patient was happy with that. It wasn't that the patient wanted to do more than that. So probably at this point in time, the cause of the present symptoms is the osteoporotic vertebral fracture with instability. So if I had the choice and if I had to treat one of the two, then my choice would be to treat the osteoporotic vertebral fracture first.
That's fantastic. And then you would counsel her about the stenosis?
Yes, I would counsel her that there is a stenosis. It is fairly tight. That may be the reason why you may be getting imbalance and may have had a fall also secondary to that. So if the ideal thing is treat both, but if we were to treat one, this would be the one I would treat first. And if your symptoms are okay and you are managing, there's nothing else required. And if you are not managing and things become worse, then we would like to then operate on you for the lumbar spine at a later date. So this is one option, unless they insist that no, we want to sort everything out. Or if your actual MRI shows an extremely, I can just about see the actual MRI. So it's a moderate stenosis. It's not very bad. So maybe there is room for conservatism as far as L4-5 is concerned.
Dr. Satyan, what would your insight be here?
Yeah, this is a very difficult case to treat because if you are going to deal only with the osteoporotic fracture and if you stabilize this patient, you're now going to put much more stresses on L4-5 with the above mobile segments gone. And then she's going to start getting much more trouble from L4-5. However, if you take the whole case and you fuse from top to bottom, she's now going to start getting proximal junctional problems and problems with long constructs, screw cutouts, etc. So you'll be jumping from the frying pan into the fire if you do that. So I would try to conserve her as much as possible.
Yeah, but it can't be conserved, unfortunately, because she's very, very symptomatic. Gautam, I see you nodding. You don't. So the worry in our heads is that if you build up a tall tower on top of an unstable base, the base will start giving way. You don't seem to have that experience in your practice.
No, we do. We do have that experience in your practice. But as Satyen pointed out, the alternative is to go down to L5. So you would go probably, if alternative would be L5 fixation, L4 fixation, you'd probably skip L3, then put in screws at L2 and probably have to go 3 levels higher up also if you're doing such a long construct, and then decompress L4-5. So to my mind, if the patient is absolutely healthy and otherwise 73 is not very old, you could think of this surgical procedure, especially since she's already going into a list at that 3-4-4-5 junction also.
Right. So it's damned if you do and damned if you don't. Agnivesh, is there a scope of just doing a vertebroplasty and getting away? Just the current.
Yeah, if especially if the patient has a lot of comorbidities, you don't want to go through a surgical procedure, which is sort of semi-indicated and based on thing that it will deteriorate. I would just do a sort of treat the fracture and not do the lumbar spine with a counseling that it can get worsened later on and it may need an intervention later on as well.
And what is your experience? Dr. Dheeraj, can I get you on board? What is your experience in using screws in such patients? Like, would you, if you had to do a stabilization like Dr. Zaveri has pointed out, would it be 2 above, 2 below, or would it be longer?
This is for me?
Dheeraj?
Yeah. So I will go 2 level up and down. And my preferred approach is intra-body bone grafting. Regarding L4-5, I like to see the dynamic use of this X-ray for lumbar instability. And if it's not moving that obvious, not moving up to grade 2 or beyond, I may just go for a decompression.
Right. Dr. Krishnan, as a neurosurgeon, how do you look at this? Is it slightly different, your outlook here?
Sir, that I think the axial pain is because of fracture. So first I would treat to fracture, and then the L4-5 just only the claudication. So you can just same sitting, you can do a I think you can do a balloon kyphoplasty at the above level and do a minimal access decompression at the lower level, so that she will be symptomatically free from both aspects.
Multiple options, but this is what was chosen. I'd like someone to comment on the validity of this procedure. Maybe Vishal, can you, if you're with us, can you tell us what is good here and what is not so good here?
Multiple things that are not so good here. One is that short segment stabilization has been done. The short segment means it's really, really short. Even for a Harrington with sublaminar wires, I think this is pretty short. It has to be minimum 3 above, 3 below. The good is that they have used wires, and wires are the best modes of fixation when it's an osteoporotic spine. The bad is that they have stopped bang at L4-5. So they have included the L3 vertebral body and the L4 lamina is paired. So that means the L3 for interspinous ligaments and ligamentum flavum has been taken down to get the wires in there. The good is that they have tried to preserve the mobility for the patient and secured the anterior column construct has been done. So cementing of that area has been able to reconstruct the anterior column. So I think this is a mix of this, but I would surely not do this because this is not what really works in my hands well for this patient. And I would really want to follow up this patient after this surgery for a little longer period of time because this has a very high
Just alluding to the vertebroplasty, Dr. Agnivesh, can you comment? Is this vertebroplasty going to last out, or do you think it's maxed out from the end plates?
I think with the posterior column support, it will go through, and we need to concentrate on anti-osteoporotics more. Yes, it's a bit too much of cement. I can't see the X-rays very nicely. If it's contained, I would believe it would last. If the cement has already extravasated through the bone, then it's not going to last.
Yeah, I mean, she predictably came back with the severe instability, probably worse than pre-op at one point. Dr. Arjun, can you comment here? Because we need some senior experts to tell us what to do from here on.
So, I mean, we are always wiser in retrospect, and I mean, the treating surgeon always tries to do with the best intent, you know. So, I mean, I think we should respect that. But yeah, I mean, there is loosening, and this basically will require revision, including the 4-5 and proximal fixation, and you know, that cement is loose there, you know. So, in a reconstruction, it will require fusion proximally, distally, and then anterior reconstruction, and if possible, you know, getting that cement out and putting a bone graft at least or something biological. But then that's a big procedure now. You know, getting that cement in is easy, but getting it out is very difficult. So I think when we are talking about putting cement in the spine, one needs to, you know, look at the long-term repercussions and you know, consequences of it and decide the indication very carefully. We had a long session on vertebroplasty.
Yeah.
That's something.
Dr. Nishant is here. He's an expert on sublaminar wiring. What do you think went wrong with the sublaminar wiring? You think the indication was poor, Dr. Nishant? Or you think the execution was poor? You're muted, Nishant.
Sir, I think the levels chosen for the fusion base is less. I think we should not have higher up, and you know, 4 above and 3 below would be ideal for this case.
But 3 below would encroach on the listhesis,
Yeah.
is it?
I think then the choice of implant chosen is wrong, I think, sir, in this case.
Yeah, because though wires are you know, touted to be good for osteoporosis here specifically, and I think all should realize that in the lumbar spine, the wires have a very, very poor stability. There's no rotational stability at all. Correct. And you know, partly reconstructing the anterior column, it's a recipe for disaster. So really, she was. Anyone has any smart plan here? This was the plan given by the second opinion surgeon that we'll take everything off and build a big tower on top of this, which seems all right. Anybody? Yeah, Agnivesh, I can see your hand up.
No, sir. I was just retrospectively analyzing that. Was it a pincer type of osteoporotic fracture to begin with in the X-ray?
Can you tell us what that is?
So that's a fracture which has been sort of coronally split into an anterior and a posterior part. And the cement is not going to go because it's not a contained cavity where the cement will last.
Yeah. So a CT would have been mandatory to,
to sort of, yeah, consider that, yes.
Yeah. So any plans now that you have the mic? Any plans here?
Sir, I would agree that we will need to take it out, do a longer construct. Yeah. I'm not sure whether we'll be able to get this cement blob out or not. If we can sort of give some anterior reconstruction from posterior side, like a mesh cage laden graft or some or mesh cage strut or something, it would be good. But a long posterior fixation is something which is mandatory now.
Going down to sacrum or stopping at L5?
No, I would stop at L5, sir. I would not want to involve sacrum because if she's osteoporotic, I might as well do the pelvis then rather than ending at sacrum.
Right. So I think everyone agrees that long fixation with an anterior reconstruction from the back. Anyone disagrees? Anyone has a smarter idea?
Sir, only one thing I would have like to add. The sublaminar could have been used as a extra support to the pedicle screws. So that will have given a dual anchorage to the spine. And also the cementing technique. It's a big chunk inserted at a very small area. It should have been a thin distribution throughout, which might have avoided this.
Yeah.
Also, another alternative was the intra-body bone graft.
Agreed. I think all counts agreed. So there's a lot of learning there. I think the biggest learning was the anticlimax in the end, that she totally settled down with 12 months of teriparatide. Clinically, she started walking, and with her walker, she was mobile. And because she was so moribund, even if she was able to walk to the loo, I think everyone was happy. So she's just as it is now. It's been 2 years and everything is as it is inside, but she's had teriparatide. So it's, saved the day for us. So it's a small learning, a small case. And thank you so much. Any comments are welcome. Otherwise, we can move on to the next case. Thank you.
So this is a lovely case, Abhay. I think a lot to learn, but I think in the initial stage, the fracture chosen for the fixation was wrong because this was a A3 in complete burst fracture. Both end plates were fractured. Vertebroplasty is not a good option for this kind of a patient. If you're going to, you can treat it non-operatively, but if you're going to treat it operatively, then you need to do a fixation. In this case, the fixation, since if we were trying to avoid L4-5, would have been 2 above, 2 below, in which case cement augmented screws would have been very, very useful. And in this case, after doing that, you could think of vertebral shortening, compress a little bit rather than trying to do, so that you get anterior column reconstruction just from in situ fusion, rather than trying to do a big anterior column reconstruction. So that would help. I'm not a big fan. In fact, I can say that in all these years, maybe I've used cemented augmented screws once or twice. I'm not a fan of segment augmented screws at all. But if you're trying to avoid it, then this might be the way to go. Use 2 above, 2 below, and cement augmented if you're planning to avoid going down to L4-5. But lovely case.
Augmented screw with the wire. Dr. Agnivesh, you have raised
Sir, in these pincer fractures, we have now experience of around 12 cases wherein we have done the cage plasty. Means originally we learned it from Dalvi sir. We have put an intra-body cage which stabilizes the sort of both the segments, the anterior as well as the posterior segments. We do 3 above and 2 below. And till now, we did not have any failure in those cases. All went to heal on well. So maybe...
What is cage plasty? Sorry.
So it's an intra-body cage placement like a T-lift, but we go through the pedicle into the vertebral body between the 2 end plates.
But how is it better than cement in that space? Why is the cage better than the cement?
Sir, it is. I think it is more forgiving. We put like a T-lift, we put the graft anteriorly first, and then we put a sort of a cage, and it has worked for us very well rather than the cement. It's sort of less hard than the cement. It has purchase in end plates. It has serration, so it sort of gets a purchase in both the posterior as well as the anterior pincer segment. And for us, it has worked very well till now.
I see this work, just that it's counterintuitive to think about it, because if the end plates are giving way, the cage is going to be sitting between 2 discs. I mean, the fault here was the end plates were giving way, and hence the cement didn't hold.
No, sir, if you see the x-rays, the sort of the anterior and posterior segments, they just sort of fell apart.
Yeah.
So it was the sort of this thing which it is stabilizing. And again, the key is the fixation above and below, which is holding it in place. It is just that if there is going to be some collapse inside, it's a flat surface. It's not a rounded surface like a cement, wherein there can be rock and rolling of the end plates. So it's a flat surface. So
that cage plasty works in a vertebral pseudoarthrosis where there is a big defect which is opening up, where both the end plates are essentially intact. Here, if it was a split cleavage fracture, you were the one who pointed that out.
Yeah,
so if it's a split cleavage fracture, the disc has migrated into that disc space. Now, where is the question of their end plates being intact, upper end plate?
Sir, this is a osteoporotic fracture. It's not like a pincer fracture in a young patient where there's a high energy trauma and the disc has gone in. They usually are low energy traumas, and we never see the disc sort of going in the vertebral body in these cases.
Okay, lovely. There's no end to this controversy, and that's why we're here. Let's hand over to the next speaker, Dr. Gautam Zaveri. Vishal, I think Satyen is doing this very loudly. So we should just move on with Gautam. Please, thank you.
All right, we move on to the next case. That was a lovely case by Abhay. Lots of points of discussion. And this thing was to present a cervical spine case. And I'm going to take you to another challenge which all of us face. So this is a 52-year-old general surgeon, had axial neck pain with symptoms suggestive of cervical myelopathy. Modified JOA score was 12/17. You can see X-ray showed multi-level spondylosis, and MRI showed hard disk osteophyte complex posteriorly with some cord signal intensity changes opposite C6-7, I think, and C71 region. So this is the patient. My first question now, let's start with our cervical man, Arjun. Arjun, the treatment options here, should you go for non-operative? He has a mild cervical myelopathy. Would you think of anterior cervical surgery? If you're thinking of surgery, would you do anterior disc replacement and fusion, or discectomy fusion, corpectomy fusion, cervical compression, decompression plus disc replacement, or would you go posteriorly for this patient?
So I would do a posterior cervical laminectomy or a laminoplasty for this patient. Laminoplasty would be my preferred choice, but laminectomy, because his lordosis is there, and he has to be operated because he's a surgeon, and if he's going to do fine work, then he needs to have his hands functioning well. I would not do anterior procedure.
Yeah, absolutely agreed that this year you would have a low trigger for operating because he's a surgeon. He requires fine motor function. You don't want him to develop moderate disability or operate on him early. The choice of surgery was anterior or posterior. Well, contrary to what you suggested, this was what was done. And I think among all the panelists here, the only person who has some experience with cervical disc replacement is Abhay. So let me put it to Abhay here. Abhay, what do you have? Any comments here?
3 or 4 bad indications here for a disc replacement. One is that it's an orthostabilizing spine. So it's already there osteophyte. It's almost like a dish on the X-ray. So it becomes a poor indication. If you had to do anterior, it had to have been fusion. The other is that it's myelopathy. And when you look at the spectrum, myelopathy fares poorly with disc replacement and radiculopathy. The third is, of course, that, if we had to have an anterior surgery, we should have had a corpectomy done because the compression was not at the level of the disc. So I think on all 3 counts, this is a badly done or a bad choice of procedure.
Perfect. So as Abhay pointed out, there were plenty of contraindications to these are some of the contraindication, instability, but this guy also had some facetal arthropathy. Other indications include primary prior laminectomy, primary axial neck pain. If there is a severe loss of disc height, then also it's a contraindication. Osteoporosis is a contraindication. And as Abhay rightly pointed out, severe spondylosis with huge osteophytes like this are going on to an autofusion, are contraindications to artificial disc replacement. This patient had all these contraindications: a very small disc space, a very large osteophytes, facetal arthropathy, not a very good indication for doing an artificial disc replacement. Whenever you're doing an artificial disc replacement, again, there are some things you must follow. A complete discectomy is essential. You must do a complete removal of the posterior osteophytes. An adequate foraminal decompression is necessary because there may be reformation of osteocytes because you are allowing mobility at that level. The posterior ligament should be removed. The bony end plates, however, must be preserved so that the the disc doesn't sink. The end plate should be parallel. The placement should be in the midline. Now, here the placement was probably okay in the midline, but it did not extend all the way up to the posterior wall of the vertebral body, which changes the biomechanics and avoid over distraction. Now, 6 months later, the patient was better. His neurology had significantly improved. He had minimal residual numbness. These were his range of motions. He was very happy with the result of his surgery, just a mild neck pain. But unfortunately, obviously, a follow-up X-ray was done. And this is what has happened here. Any thoughts, Dheeraj, what has gone wrong and what has happened over here?
Sir, as we rightly discussed,
Dheeraj, we can't hear you very well.
Can you hear me now?
Yeah.
Yeah. So as we rightly discussed before, the choice of procedure is not acceptable. Also, also the posterior decompression is not done appropriately. As we see on the left side, the osteophytes are still encroaching the spinal canal, and it is going to be have failed.
Okay. So, and what do you see X-rays? I mean, what has happened over here? Agnivesh, what is happening?
There is an autofusion which is taking place at the C5 disc, sir. It's already fused, and the lower one, I feel there is a peri sort of implant. There is a lucency and subsidence, which has caused the two sort of those polyethylene spacers and all to fall apart. So,
Right.
but again, it is stabilizing by an anterior osteophyte.
So Manish, you're here now. Can I ask you, what would you do at this stage? And this guy is not very symptomatic, but you can see there is osteolysis of the vertebra. It is basically a subsidence of the cage, both at C5-6 and as at C6-7. He's got subsidence of the cage into the vertebral body. Patient has been advised. He was operated initially. Sorry, I see Dr. Murli was here. So neurosurgeon, he was operated initially by a neurosurgeon, went back to the same neurosurgeon, was advised surgery. So Manish, what would you do?
So as I've just joined, sir, I don't know the entire details of the case.
Yeah, he had cervical
Just
myelopathy. He went through artificial disc replacement. Now he has come 6 months later. He is absolutely fine clinically, but he has got this X-ray picture.
So I can just wait and watch. It's already forming osteophyte. It's a very expensive fusion for the patient.
Yeah. So that is what I advise the patient, exactly what Agnivesh said and Dheeraj said, that at C5-6, so already there is an anterior bony mass being formed. At C6-7 also, except for a small gap, everything is settling down. Probably the patient would not have any problems. The fusion would occur and there is no reason for us to intervene. So I sent the patient off and told him, do not get operated, just leave it alone. And but unfortunately, surgeons being surgeons, they are not happy with simple response. So he went through another surgery, an anterior cervical discectomy and fusion. And of course, he got good relief of pain. His neurology has settled down and he's happy with the surgery because he's got a good result. So thank you very much. Just a case that there is, as like in Abhay's case, we're just giving injection teriparatide and waiting, help the patient and patient settle down. There are cases where you can wait. Every complication does not require bigger reaction from you. Should I stop, Agnivesh? Should I go ahead and present the second case?
I think we can go ahead with the second case. We have some time.
Okay, this is a hypertensive diabetic. Actually, I'll skip this. I'll go to case 3. Case 3, which is far more interesting because I don't have a solution for this. Sorry, I just went ahead. Shit. So this is a 11-year-old boy, 14-year-old boy who came with severe upper back pain and paraparesis, spastic paraparesis. This was his MRI picture. Right up your sleeve, Dheeraj. This is the type of cases you see in JJ hospital all the time. So what should I do? Surgery, no surgery?
What was the neurology, sir? So what was the neurology?
Paraparesis, grade 2 power.
Okay, sir. So you have the X-ray CT, sir?
No, I don't. This is the upper dorsal spine. So therefore, the patient's X-rays did not show anything such significant for us to really help.
Okay, so almost 1.5 body at the cervicothoracic region has been resolved. There is a deformity of almost 70 degrees, maybe more than that. Yeah, and with huge abdominal mass compressing the which is causing the so I would like to check on fraction how much I would like to
Dheeraj,
sorry, Dr. Dheeraj, can you turn your video off? I think we'll be able to hear you better if you turn your video off. There is some breaking of voice.
Now to speak, Dheeraj.
So almost 1.5.
So what would be your plan? Surgical, non-surgical here?
Basically, the patient is having non-functional power with significant destruction, especially in the cervicothoracic region, and with a deformity. My plan will be surgical, sir.
If this patient had nil neurology, would you have operated or would you have treated non-operatively? You asked that specific question, so I'm going to ask you in return.
Right. Still, my inclination was towards surgery because the deformity is at the junctional region and there is significant destruction of almost more than a body.
Yeah, so it's almost 90-degree kyphosis. Here, neurology doesn't matter. You have to operate because there is severe deformity which will progress with age and instability. So operation is a must. Arjun, in Wadia Hospital, what sort of surgery does this patient merit?
So me and Dr. Nene have done a lot of these cases, together. And this child will need a cervicothoracic instrumented fusion and costotransversectomy, getting anterior, decompressing the abscess, and then trying to get some anterior support, and the issues here basically are the proximal fixation. So you should have sublaminar wires available and try to get pedicle screws in C7 and then instrument proximally with sublaminar wires if you can't get good lateral mass fixation.
So how much proximal should we go? Should we go up to C7, C6, C5, C4, or even
I would go 3 levels above here and 3 levels below, because it's at the junctional area and the kyphosis is significant.
So this is up to D2 is the level. So you would probably end up going up to C5, you say?
That's correct, yes.
C5, C7, and D2, D3, D4.
Yeah, we can ask Dr. Nene also, since we do.
Yeah, so Abhay, challenges here in terms of doing a posterolateral approach in the upper dorsal spine. What would you advise our listeners? How should we tackle a posterolateral approach in the upper dorsal spine?
It's a very crowded area for the ribs. So unlike in the lower thoracic or thoracolumbar, where you can get a real good access, here you're just narrowing down on in phoning down, and so it's very hard to really get there. The other is that because the hold of the implants is not so good, to get a clear correction with the screws is hard. So you're actually fixing it with end plates that are angulated, and that's why sometimes you want to give a traction. This is slightly too low for a traction. You were slightly higher with the traction. You could have opened him up and then put instrumentation in situ. So Arjun would tell you that though we've done several of these, we've had situations where those posterolateral grafts have given way, and we've had reason to go back from the front and then reinforce. But it's a really tricky area, and I really don't know. I mean, I would still go by Dr. Arjun's plan because that's correct, but it may not work in 10%, 20% of cases.
Thank you, guys.
The key is the resistance pattern. Is this a MDR or is this a sort of sensitive? So if it's a sensitive, everything is going to kind of go well post-op, etc. But if it's turned out it's resistant and we don't have the drug sensitivity, then there will be problems basically.
Yeah.
So having a good culture.
The challenge as Abhay mentioned, in the upper dorsal spine is that the vertebral bodies are no longer rounded; they are triangular. The interpedicular distance is short. So therefore, putting in your anterior strut graft, whatever mode you choose, is far more difficult. You require more access from the posterolateral region. And the ribs are fixed ribs. The transverse process is going vertically up in the air. The rib is also going vertically and then going down. It is not a flat rib. So you have to knock off the medial third of the rib. Otherwise, you will never be able to access adequately anteriorly. And that is a very, very key important area. Plus, you have to remember in this area, the thoracic spine goes into kyphosis. So putting your anterior strut is a little bit more difficult. It doesn't look very pretty sometimes because your cage looks or strut looks tilted. Anyway, we operated as per the plan suggested by Abhay and Arjun. And I went up all the way up to C4, C5. I always skip. I find it very difficult to pass screws both in C7 and D1. So if I'm putting screws in D1, don't put in C7. If I'm putting in C7, I don't put it in D1. And then I go up. And that's why I've gone one level higher at C4. Plus, if you see the lordosis is changing and going up to C4. So therefore, I thought that this would be a better way to do the fixation. This is the post-op X-ray. We did a transpedicular costotransverse decompressectomy, anterior column reconstruction. And patient turned out to be sensitive to all drugs. So we put him on 4-drug AKT. He responded brilliantly, neurologically better. Everything is okay. 6 months down the line, this is the picture on the right. Now, first question is, Agnivesh, why did this happen? I mean, we took care. We did not open up even the interspinous ligament, the facetal capsule. Nothing was opened at that level. We kept the facetal capsule, and this thing intact, and in order to prevent this proximal junctional failure in young patient. 6 months down the line, from the tuberculosis standpoint, is absolutely fine, but he's asymptomatic. There is no neck pain. He has no consciousness that he has developed a deformity in the neck. So in every way, the patient is happy, but I am worried with this X-ray picture. What probably led to this problem, Agnivesh?
It may be an issue with the global balance. Like if his global balance is in negative, then he will always compensate it with the head forward position to sort of look down. That could be one issue. The facetal violation and all you have already taken care of. But I don't know. I don't have an answer to this at present.
Vishal, what should we do now?
Nothing, sir. I think at this point.
Asymptomatic.
Sorry?
Patient is asymptomatic at present with this. So what should we do?
I think there are these hyperextension braces available in market. That is what one thing that I would at this point in time go for. And I'll keep a close watch on this deformity. Here, the sagittal balance overall is surely not the cause of this deformity, because if I see the post-op X-ray, the head is actually in positive balance. It is not in negative balance. It is already falling ahead of pelvis. So that may not be the actual cause of this deformity going by. The child is only 14 years. So on one hand, taking care of with a brace is one part of it. The second part of it is to really look for and evaluate for any joint laxity, because it is very commonly seen in Ehlers-Danlos and Marfan's, where the child actually starts presenting with these kind of deformities in craniovertebral junction areas or in other parts of the body only after the puberty is come. So at 12 years you operated, patient is 6 months post-op. I think this is something that will surely run into my mind. Are we really dealing with any kind of connective tissue disorder or not? But at this point, nothing to be done, only hyperextension brace. Observe the patient very closely at 6 monthly interval and keep the patient communicated that you may require an extension if this keeps progressing.
Sir, was a C7 laminectomy done in this case?
It won't matter. We have already bypassed that level.
No, we did only, this was D2. So it was D1 and D2 which was done.
My other part during the surgical plan, Dr. Gautam, would be, if you see in the MRI, this is like a long neck. The D3 is also jutting out of the cervical thoracic inlet. If you go to the pre-op images, I would actually want to limit the number of fusion because he's a child and rather go anteriorly. If you see the sternum, the T3 is also jutting out of the thoracic inlet. So I was just thinking whether that is an option. We put the patient on traction, do only a posterior small level decompression, single level above below fusion, and from front come and do that corpectomy and put a cage expandable one. Maybe that could save the levels for us in a child of this age group. I'm just thinking loud because here the spine is really long with a very, very long neck.
I agree with Dr. Vishal. Probably nowadays I've started putting pedicle screws, cervical pedicle screws. So you could have probably limited the levels in the cervical spine, and that would have saved, and plus an anterior graft.
Yeah.
The only other thing that comes to my mind is
thought process. Yeah.
The other thing that comes to mind is it is fairly evident in literature, but the literature is skewed towards the adult patients, where the more you correct the deformities, the more are the chances of a PJK, like what is happening here. But in TB, it is not been reported, because in TB, grotesque deformities 100-degree also do not really contemplate into PJKs, and there is a starking contrast in post-tubercular deformities versus adult degenerative deformities, where correction of deformity in degenerative cases has a higher chances of developing PJK. The same results do not apply to TB patients. Here, I don't know whether that principle applies or not, but that also runs into my mind. Connective tissue disorder, excessive correction of the deformity. 3 is saving the levels probably could have been done. And I think at this point, we should just observe, give a hyperextension brace, and also evaluate from connective tissue disorder point of view.
Lovely. Thank you. I think that's a very fruitful discussion. I think a very valid point made by Vishal, that maybe this is a case where we would have considered an anterior approach along with posterior to limit the number of levels that we are doing. But at present, certainly I've given him an SOMI brace, a sterno-occipital, to keep him in extension. He refuses to wear it. So there's not much to be done right now. Wait and watch and see how things go. Thank you very much. Just to highlight the problem that can occur. With this, I hand the mic back to Agnivesh to take it forward.
Thank you so much. Thank you so much, Gautam sir, for your excellent cases and insight. So with this, I would like to move on to the next case by Dr. Nishan. Dr. Nishan, can you please start the screen sharing?
Is my screen visible, Agni?
Yeah, we can see that. Please start your PPT.
Yeah, so moving on to another pathology from degenerative and infection. So I'm presenting a case on trauma. So this is a 45-year-old gentleman farmer and history of fall from bike. He's got a 6 weeks old injury with bowel bladder involved and Asia C. This is his X-ray if we see. So he's got a vertical split fracture at C6 vertebrae. And on the lateral view, you can see there is some destruction of the superior end plate of the C5, C6 vertebra. This is his MRI. And you can see there's some amount of subluxation of C5 over C6 with kyphosis and signal changes at the level of injury. So got his CT scan done, and you can see there's destruction of the end plate at superior end plate at C6 and vertical split fractures at the level on the coronal section, axial sections, as well as the coronal section. So how do we proceed with this case? So should we conserve Agnivesh? Hello?
Yeah, sorry.
So
can you go back to the case, please? Just the X-rays, yeah.
To begin with, this is the X-ray and 6 weeks old injury with Asia C.
6 weeks old, yeah. And to the MRI?
So it's got some kyphosis at C5, C6 with subluxation of the C6 vertebrae and some signal changes, cord signal changes. And this is a CT scan. There are some posterior injury of the posterior spinous process is injured at the C5 and C6 level, and we've got a vertical split fracture of the C6 vertebra as well.
Right. So basically, it is more like a 3-column injury with a neuro deficit, because the anterior, middle, and the posterior there is
Correct.
a break with a neuro deficit. I would not be keen on conserving this patient.
Okay.
Unless there is a contraindication, I would think of a operative treatment in this.
So, anybody in the panel who would want to conserve this case? Vishal sir.
Yes, Nishant.
So have you been following the case?
Yes. So what is the neurology in this patient?
Asia C.
Basically non-walker.
Yeah, non-functional power in the lower limb, but he's got spasticity.
And can we also see the MRI once?
Yeah.
Yeah, I think so. Incomplete neurology is straightforward surgery. There is no doubt about it. A patient with incomplete neurology, irrespective of whether there is any potential for recovery or not, straightforward for me, it's a surgical case. Now, the only two options that we... Yeah, sorry.
Vishal, have you seen there is a more of a spinal cord injury rather than a compressive component?
Yeah, there is a contusion, agree, but
old injury.
Dheeraj, I agree that number one, this patient may not recover at all. May or may not recover, but it's an incomplete injury. So if we do not operate, the potential of a grossly unstable situation going into a complete injury is always there. And that is why for me, incomplete injury, even when there is even mild structural compression, I would surely not want to leave an unstable situation there, even when the structural compression is minimal. To stabilize that is the primary goal. So here the goal of surgery is to stabilize this segment. And to stabilize this segment, irrespective of decompression, I think for me, a easy thing would be to do an anterior thing. An anteriorly 2-level corpectomy with a plate is something that I would surely want to contemplate.
Nishant, what is the level of neurology? Nishant, what is the level of neurology?
Sorry. Please go ahead one by one. Dr. Dheeraj, go ahead, please. Then followed by Dr. Manish.
Yeah. So for me, it's more of a conservative trial because the injury is already 6 weeks old. It is more of a spinal cord edema throughout the MRI which is seen. Also, there is no on axial cut. I haven't seen any compressive component. So just
MRI,
the cord
please,
edema
MRI.
without a compression and just the grade 1 listhesis for a 6 weeks old injury. I am not for a surgery.
So one point is that the reason that this is not a stenotic central canal with the central cord syndrome. So this is a normal canal. So the reason there was a neurological deficit itself proves that the injury was unstable to begin with.
No, may I, Agni? There are
please go ahead.
Enough points to tell that this is a grossly unstable injury from Slick's classification also. Even if we go by classical Allen Ferguson classification, this is a kind of flexion hyperextension injury with a vertical compression component to it. If you see the X-rays, if you see the MRI, there is a subluxation of C5 on C6 already with a disc disruption, point number 1. Point number 2, there is a vertical split fracture of C6. Point number 3, there is a chip fracture, which is a classical point of avulsion of ALL there. If you see on the CT scan also, it is very evident. So this is an unstable injury. There is no doubt about it. And from the modern Slick's classification, it really falls into a place where you need to stabilize this to prevent post-operative or post-traumatic kyphosis in such patients, irrespective of the neurology. Agreeing to the fact that there is no obvious structural compression today noted on MRI films. However, this is a classical unstable situation. Leaving it as such may lead to a post-traumatic kyphosis with delayed worsening of neurology, which has always been documented in evidence also. So for me, it's a surgery to stabilize the patient, which may or may not give any neurological recovery to the patient. And of course, it can easily be anterior cord syndrome, which will, if it's only purely motor with only anterior cord syndrome, the recovery chances of this really, goes exponentially high.
Right. Dr. Vishal, thank you so much. Dr. Manish,
just
you have
one more point. Just one point, Agni. If this was a fresh injury, I can understand this is a grossly unstable situation. But for a 6 weeks old, I think it should have been come up by now.
Right. A very valid point. Dr. Manish, you have to add anything?
Yeah, I just wanted to know the level of neurology because the cord edema is going all the way up to C5, C4, if I'm not wrong. So level of neurology will also decide my approach. This is a clearly surgical case, as very nicely pointed out by Dr. Vishal. Only my choice of anterior or posterior would depend on what is the level of neurology and is there a risk of post-op ventilator. Although it's an old injury, but patient can still decompensate, needing ventilation. So if that is the case, then I would like to go posterior.
Right. Dr. Nene, are you around? Nene, sir, you're around?
Yeah, I'm around. I'm just getting too
Sir, your comments on this case. 6 weeks, unstable injury, no static compression at the cord, conserve or operate?
I'm not sure, but instinctively I would conserve. But I understood all the arguments. Instinctively, I would conserve and wait for something to go wrong. Like Vishal said, delayed kyphosis. If we start seeing that, then I'd probably, get in because it's a losing battle with him being quadri, right?
Right. So Dr. Nishan, what did you do with the case? Please tell us.
Basically, patient wanted a single procedure. I thought initially of doing a 360-degree fusion for this patient, anterior and posterior, because being a 3-column injury, the more rigid the fixation, I think we can be more aggressive on the rehab part for the patient. So what I did was I went in and I put pedicle screws from behind and tried to restore the normal alignment. And this was a freehand pedicle screw fixation under fluoroscopy.
Right, great. Did you do any decompression in this case or only fixation? Dr. Nishan? I think we have disconnected. So one quick
question. I think
question.
there would be a good indication to do just a stabilization without any decompression in this patient. Yeah, that would be the plan of action.
True. Let's ask Dr. Murli Krishna, neurosurgeon, from his perspective. Would he decompress or he's okay with fixation only? Dr.
I would like to decompress the spine also, so along with the decompression. So once you use the pedicle screw, is a 360-degree. I mean, all 3 columns are involved. No need for anterior reconstruction, but still, I would prefer to do a decompression at that level.
Right, and what are your points for the decompression? Why do you want to do that?
Yeah, still, although it's a 6 weeks old injury, but still, there can be good chance of recovery with a decompression. That's what I think.
Right. One last question to Dr. Arjun. Dr. Arjun, is there a medical legal implication if you do not decompress and this patient does not improve?
I mean, here basically there was no severe stenosis. Actually, there was no severe stenosis. It was a cord signal change. So, I mean, at 6 weeks, I agree with Dr. Nene. You could kind of wait it out also and just keep the patient in, in a collar and it's going to heal. If you have to operate, then I would do a corpectomy and I'd supplement it with a posterior fixation, because just doing a corpectomy with a 3-column is unstable. There can be a failure. Then I'll do a corpectomy, get that, fragment off, and then do a posterior fixation to supplement it. And the problem is basically there's an anterior compression. If there is a compression, it's anterior. And I actually in this case feel there is mainly a cord signal change because of the initial trauma. So I'm not sure actually.
Right. Okay. Thank you so much for this nice case, Dr. Nishant. With this, can we move to the next case by Dr. Akhil?
Yeah, sure. Is my screen visible, Dr. Akhil?
Yeah, Dr. Akhil, it is
all
visible.
right.
Please go ahead.
So mine is more like just wanted to concentrate more on the imaging aspect rather than actual therapeutic dilemma. So I had a 56-year-old gentleman who presented to my clinic with back pain and right leg pain. It was ongoing for the past 2 to 3 years. Currently, was unable to walk for more than 5 minutes, did not give any specific history, had tried all conservative treatment options, tried epidural steroid, and got relief for 4 to 6 weeks. On exam, neurologically, everything was okay. Distal pulsations were well felt, reflexes were all present. This was the X-ray that he came to my clinic with. We can see that there is some instability present at L5S1. And but not very convincing. I just went ahead and got a standing X-ray done for him. He also got some FlexX views, which were also done outside, and a CT scan, which shows a fairly good alignment on the CT scan. The only thing I did is I got a standing X-ray done, and it shows a significant amount of instability. So, I mean, this was just one point I wanted to make, that it's very important that if you're suspecting instability, one should get standing X-ray done. On the AP also, we can see that there is some spina bifida thing that is going on. And based on this, there is a very high pelvic incidence. MRI shows significant foraminal stenosis on the right side. Other thing to appreciate on MRI is that he had a significant a fat layer. So the spine was quite deep. And again, just to concentrate this point, the CT scan showing fairly good alignment and the slip that is significant on standing X-ray. I got the basic parameters. The BMI was on the higher side. Pre-diabetic, lumbar lordosis of 65. Proximal was contributing to almost 40 degrees, was really trying to compensate. Distal lordosis was 40, but majority was happening at L4-5. Only 8 degrees of lordosis were from L5-S1. So majorly with this, I definitely wanted to operate on this. Based on these parameters, I would like to have an opinion of whether you would want to go ahead with an open surgery or anything else that they would want to consider for him.
Right. So, Dr. Arjun, grade 1 to listhesis, symptomatic, not grade 2, means it's like a borderline 1. So, symptomatic and having some instability on standing X-rays, there's a listhesis which is there. So, what will be your treatment protocol in this?
The patient is symptomatic, has failed conservative treatment trial, and wants to go ahead with the surgery, and is functionally disabled, then I would do L5-S1 fusion. I would do a posterolateral fusion. I would do a posterolateral. If she's osteoporotic, then I don't like to do interbody. So it doesn't matter whether you percutaneous. I would prefer to do this open or MIS. It doesn't make much of a difference, I think. It's okay.
Right. Can we get opinion of Nene sir on this? Nene sir, what will be your extended rehab or surgery or blocks?
I would take this patient by the surgery, assuming that all the indications are there. Of course, you have to rehab injections, all that. So only if the indication is for surgery, I would do a T-lift, 1 level T-lift. And I'm not so much worried about the high incidence angle and there's a mismatch, right, Akhil? Between the
yes, there is significant mismatch.
So because a high incidence angle and a sloping sacrum is very surgeon protective. It is unlikely to fail, even though I don't get a lordosis to match.
Okay. Just so would you want to do the interbody or not? Because I think Dr. Arjun mentioned that he would not want to do an interbody. Probably
I just want to do it to get a better fusion in my hands. In my hands at L5S1 postprandial doesn't seem to work as much because of the small transverse process. Can have the AP X-ray. Sometimes if it's really seated low, the L5 seated low, sometimes you can still do it. But if the L5 is seated, yeah, this is still, you could do it. But I would still do an interbody, but that's mainly because it's an easy procedure for me.
Correct. Dr. Arjun, like, why would you not want to do an interbody? I mean, just a fusion post-lateral.
So if there is osteoporosis, then I avoid.
There's no osteoporosis actually.
You can go ahead and do it. Fine. I mean, it's okay. I think it's the results are equivalent basically. I don't think it makes much difference. It's a degenerative; it doesn't matter that much. If it's a ischemic,
it's actually
you should ideally do antibody. But if it's an osteoporotic patient, then I avoid it.
All right. Okay. So, I mean, it was just that I wanted to concentrate more on getting a standing X-ray done. It definitely points in favor of an instability. It's more of an ischemic defect that is happening. Considering all the parameters, I went ahead and did an MIS T-lift. I got a reduction pre-op, put in a 22 millimeters tube. I usually like to put the cage before putting my screws, and this was the post-op X-ray that I got after this. Had a fairly good alignment once again. The lumbar lordosis was within 11 to 12 degrees of the pelvic incidence for him. Patients' pain, especially the radicular pain, rapidly resolved. Any comments?
Dr. Akhil, any technical challenges while putting the MIS S1 screw?
Yes, correct. So, I mean, he was a big guy. I remember Dr. Vishal sir also telling that sometimes the challenge for me is to get that anterior cortex pierced in an MIS. In this, at one side, I was able to get the anterior cortex, but on the other side, I was unable to get. Getting the cage inside was a little challenging because of the angle. So I did some manipulations with the inclination of the table. But apart from that, I think for such a big guy, I usually prefer doing an MIS rather than an open surgery. Just that's my preference for it.
Right.
I don't know if Dr. Vishal sir would like to add something to this. Good morning, sir.
Yeah, I think I can't see Dr. Vishal here. So, Dr. Manish, sometimes the L5 pedicle in these cases is quite thin and dysplastic. So,
yeah,
what is your experience in that?
Yeah, so to start with, this is not a dysplastic listhesis. This is a simple ischemic listhesis. So this is not a dysplastic listhesis. That L5, the L5 spinous process spina bifida that you see, that is not a classical finding of dysplastic listhesis. It's usually when you have S1 spina bifida, that is a classical finding of dysplastic listhesis. So a straightforward ischemic listhesis, and he's done a good job. It's a MIS case. You can probably bicortical S1 fixation would have been good, but there are difficulties.
Right. Dr. Arjun, any more questions? Any comments from your side?
I think it's well executed. It's well executed. I think it's well executed. I think there's CT. I felt on the CT there's osteopenia actually. You know, if you look back at the CT scan, if you go back to that CT, you will see that it's a little osteopenia.
Still, with this kind of higher lordosis and all, would there be a higher challenge in putting your rods in, especially if you're not putting those through the tube rods?
Yes, sir. But I think with the amount of cases that we have done, we have tried to circumvent those. Usually, the Medtronic system works quite well in putting the rods. With regards to this, debut sometimes can be challenging, in which you have to put it through the extensions.
I think that the trick in these cases is to sort of go from the other side. Like normally you put the upper one as a closed slotted one from where you put the rod. So maybe in this case, you put that towards the S1 side. So you come from the opposite side. You get a better chance of lowering the rod. But again, it's a bit of challenge in cases where there is high lordosis. Right. So thank you so much for the discussion. I thank the panelists for giving their valuable time, valuable inputs, and we have learned a lot of working and practical points from these cases. So I hand it over back to Dr. Arjun and take it forward from there.
So thank you very much. It was a great session, and we learned a lot listening to everyone. And thanks for joining us. And I'd like to sort of give Satyan and Kshitij, due credit, because all this is thanks to their efforts. We are just conducting this today, but actually they put in hours and hours in making this program. So congrats, Satyan, and thank you for involving us.
Thank you, Arjun. Thank you, everyone. I want to, on behalf of Bombay Spine Society, I want to first of all thank all our faculty, all our panelists here. You've been great. Thank you for giving your time and your efforts in making this a very good meeting. This is the first part of our annual conference, which is the BOSC, our operative spine course. We continue with the main conference, and in keeping with our, we are going to do this on the weekend again, so that we don't get affected on weekdays. We've had very good attendance yesterday as well as today morning. So we will again start on Saturday evening. The main conference starts at 4 o'clock, but we start at 3 o'clock with the industry workshops. So I encourage all of you to be present for the industry workshops and the main conference. And I also thank all delegates to watch to be here. And I invite you again on 20th of November, Saturday evening. We will have both Hall A and Hall B. You can still look at the program and attend the hall where you find more interesting. And I'll see you then. Thank you, everybody. Can stop the live.